So now you are not doing.
Yeah. Now I've turned it on. Okay.
Thank
Just
you.
give me a second. Give me a second. Okay, so today we discuss the acid-base physiology. Okay, and here first you have the metabolic acidosis, and of course you will, because it is an acidosis, the overall pH of your body will decrease. Okay, and because it is a metabolic acidosis, so you will have a respiratory compensation. Okay, you will have a hyperventilation, and as a result you will have a low PCO2 in the metabolic acidosis, and that's why it is the acidosis, of course. Okay, compensatory response will be the hyperventilation, and this hyperventilation will leads to the low level of this PCO2. Then the metabolic alkalosis, in which you have too much of base, for example, the bicarbonate. So you will be having a high pH, high level of bicarbonate. Okay, respiratory compensation will occur, and you will get a hypoventilation, and as a result, the PCO2, that the partial pressure of CO2 in your body, will increase as a compensation. Okay, then you have a respiratory acidosis. Okay, in this case again you will have a low pH, but look at the PCO2 level, because this is a respiratory acidosis. Okay, you will be having a high level of CO2, and this high level of CO2 is causing the acidosis. Ultimately you will have the metabolic compensation. Okay, and as a result your body will try to retain the bicarbonate, so you will have a high bicarbonate level. Okay, so the renal reabsorption of the bicarbonate will be increased, and this effect is always a delayed type, not an immediate type. It takes around 1 to 3 days at least to get this increased level of bicarbonate. Similarly, you have the respiratory alkalosis, and the primary defect is the low level of PCO2. It is because of a hyperventilation, maybe. Okay, so ultimately you'll be having a high body pH with low partial pressure of carbon dioxide in the body, and and this metabolic compensation occur by increasing the secretion or excretion of the bicarbonate. So you will be having a high level of bicarbonate. Increased excretion of bicarbonate. That means ultimately you will having a low level of bicarbonate. Okay, you don't need to remember this equation. Okay, just remember this equation. Okay, and this is a Winter's formula. Okay, so Winter's formula states that for a compensation, okay, the PCO2 will be equals to 1.5 times the bicarbonate plus 8, and it could be plus minus 2. Okay, so it basically predicts the level of this CO2 in your body whenever you have a metabolic. So yeah, whenever you have a metabolic alkalosis, it will predict you the acidosis type. Okay, how many times the PCO2 will be there in your body whenever you have a low level of this bicarbonate or high level of this bicarbonate. Okay, so please remember this Winter's formula. Okay, so whenever you have a metabolic acidosis, okay, what should be the level of the PCO2? It will be predicted by this formula. Okay, you just put the value of bicarbonate there, and you get the value of PCO2. If the patient has a high PCO2 or lower than what would be expected by this formula, you can have a mixed metabolic acidosis, alkalosis, or something like that. Okay, so for the compensation, remember this formula, very important. Okay, so now let's discuss the acidosis and alkalosis in the body. Okay, you know that the major functions of your kidney is to maintain the pH and electrolyte balance in your body. Okay, whenever you have a change in pH, the kidney will try to compensate it by increasing or decreasing the excretion of the bicarbonate or the acid from it. Okay, the kidney always try to increase the excretion of hydrogen ions. That means the protons, that means the acid. It will always try to excrete the acid, and it will always try to reabsorb the bicarbonate. Okay, remember these two things. So that means whenever you have any alkalosis, in that case the reabsorption of bicarbonate will decrease, and the secretion of acid will decrease for the alkalosis. Similarly, for the acidosis, secretion of acid will be increased. that means excretion of the acid will be increased, okay, and the reabsorption of the bicarbonate will be increased. Okay, so do remember two functions: acid excretion and bicarbonate reabsorption. Okay, so let's discuss the acidemia and the alkalemia. Okay, when you say that the patient is having a acidemia, that means the pH will be less than 7.35. Okay, and when you say that the patient is having a alkalemia, that means his pH must be more than 7.45. A normal body pH is, you can get this range, that will be 7.35 to 7.45. This is a normal pH of your body. Okay, let's discuss the acidemia first. In the acidemia, you will ultimately having a low level of pH. If it is a respiratory acidosis, then it must be due to the carbon dioxide. And if it is a metabolic acidosis, that means it must be due to a decreased level of bicarbonate or addition of acid. So first, let's discuss the causes of the respiratory acidosis. In all of these causes, you'll be having a high level of CO2. And this increase in the CO2 ultimately causing the acidemia. It will be decreasing the pH of your body. Causes includes the airway obstruction. Likewise, you can have this pneumonia or a pulmonary edema that can cause a airway obstruction. Okay, any kind of aspiration of any foreign body can cause this obstruction. You can have a hyperventilation because of that. Acute lung diseases can cause it, like the pneumonia again. Okay, ARDS can cause it. Chronic lung diseases like the fibrosis in the lungs. Okay, they can cause a COPD, for example. You can have the hyperventilation in that. Opioids and sedatives, they causes always the acute acidosis. An hour ago, the patient was absolutely normal, and suddenly within an hour, patient develops the acidosis, acute acidosis. So think about the opioids and sedatives, because whenever you give the patient opioids, it causes a respiratory depression. And similarly, the sedatives can cause a respiratory depression. So whenever you encounter a patient having an acute acidosis, okay, think about the opioids and sedatives first. Okay, then you have a weakening of the respiratory muscles, and that can be happen like in case of the myasthenia gravis, right? And in case of your remember the inflammation in your nerves that and that causes ascending paralysis.
Guillain-Barré?
Guillain-Barré syndrome, yes. Okay, so remember the myasthenia gravis, Guillain-Barré syndrome, they all can cause the weakening of the respiratory muscles. Okay, and remember a toxin name which can cause the paralysis?
Botulinum.
Botulism, yes. So they all can cause a weakening of the respiratory muscles, can cause the hyperventilation. So in all of these causes, you're having a high level of PCO2. And this PCO2 increase the partial pressure of carbon dioxide. Whenever it is increasing, it is forming an acid in your body, and that causing the acidemia. Compensation will happen. And for the compensation, you will be having a increase in the bicarbonate. So whenever you have a respiratory acidosis, it will always be a metabolic compensation. And in the metabolic compensation, you will be having an increased reabsorption of the bicarbonate. So a high level of bicarbonate with acidemia, think about a respiratory acidosis. Okay. For the acute, you must remember for every 10 mm of Hg increase in the PSO2, okay, 2 milli equivalent of bicarbonate must be increased acutely. Okay, so for example, the normal, let's say the normal PCO2 levels is 40, and the patient is having a PCO2 level of like say 50. Okay, so the metabolic compensation must be an increase in the bicarbonate from 24 to 26. Okay, because for every 10 mm of Hg increase in partial pressure of carbon dioxide, you will be having a 2 milli equivalent increase in the bicarbonate. So for the acute compensation, you will be having around level of 24 to 26. For the chronic compensation, okay, for every 10 mm of Hg increase in PCO2, you must be having a 4 milli equivalent increase in the bicarbonate. So if you're encountering a patient who is having a PCO2 level of 50 and a bicarbonate level of, let's say 28 or 29, okay, that means he's having and with a pH of less than 7.35, that means he's having a respiratory acidosis with a chronic compensation. Okay, you can also have a decompensated type. In a very acute cases like the opioids and the sedatives, patient always have a decompensation. That means the bicarbonate level will remain on the 24 only, neither increase nor decrease, right? And within 24 hours, you will have an acute compensation, that is 2 mm of 2 milli equivalent mole increase in the bicarbonate. Then with the chronic time, like within a week or within a month, you will have a 4 milli equivalent increase in the bicarbonate for every 10 mm of Hg increase in the PCO2. Is that okay?
Yes.
So step 1 can frame the question by asking you whether it is an acute compensation or a chronic compensation, or whether it is a compensation at all. So for that, you need to remember this formula, okay? Acute 2 and chronic, always 4, okay? And if the equation is not, if the answers are not fitting in this equation, that means he's having a different type of thing, For example, in a normal scenario, whenever you have a respiratory acidosis, it will always be a metabolic alkalosis, right? As a compensation, right?
Yes.
But you can also have a mixed respiratory acidosis and metabolic alkalosis. And for that, you will be having a bicarbonate more than 5 or 6 increased. Let's say the patient is having this PCO2 level of 50. For a normal compensation, he must be having a bicarbonate level of 28. Okay. But instead, the patient is having a bicarbonate level of 32 or 34. So you immediately know that the patient is having a mixed respiratory acidosis and a metabolic alkalosis instead of a compensation. So these equations will help you determining whether it is a compensatory response or it is a pathological response. Okay.
Okay. Yes.
So remember these causes, remember the PCO2 levels. Now comes the metabolic acidosis. And this metabolic acidosis can be because of two things. One is the loss of bicarbonate. And whenever you have a loss of bicarbonate, I told you the bicarbonate and chlorine always goes opposite, right?
Yes.
So whenever you have a low level of bicarbonate, the chlorine level, the chloride ion level must be increased in order to maintain the electrical neutrality. And that's exactly happened in the non-anion gap metabolic acidosis, this acidosis. Okay. All the causes of this normal anion gap metabolic acidosis includes the loss of bicarbonate as a pathology. Like in case of hyperchlorinemia, when I told you, whenever you have a high chlorine level, you always have a low level of bicarbonate. And that is a general rule, always goes opposite. Okay. In the Addison's disease, okay, you will be having a low level of aldosterone, and as a result, you cannot reabsorb the bicarbonate. You will be having a loss of bicarbonate, and as a result, high level of chlorine again we'll see. In the renal tubular acidosis, especially the type 4, I think, yeah, the type 4 and type 2 again, okay, you will be having a loss of bicarbonate, and that causes a normal anion gap metabolic acidosis, right? Similarly, in case of diarrhea, you will be losing your bicarbonate in the GIT, and as a result, you'll be having a metabolic acidosis. Okay. In the acetazolamide therapy, which is inhibiting the carbonic anhydrase, you cannot reabsorb the bicarbonate in the PCT. As a result, you will be having a loss of bicarbonate. Spironolactone inhibiting the receptors for my aldosterone. Again, you'll be having a loss of bicarbonate. Saline infusion, that includes the chlorine again. Okay, with the every saline, you always give the patient chlorine, sodium, other electrolytes. So that again causes a high level of chlorine. And whenever you have a high level of chlorine, you always loses the bicarbonate. So in all the cases, the primary defect is the loss of bicarbonate that is causing the acidosis. Is that okay?
Yes.
So this is the normal anion gap metabolic acidosis. Please note, for the metabolic acidosis, the bicarbonate levels are always less than 5. About the PCO2 levels. Okay. Now, second, you have an increased anion gap metabolic acid. What is this increase and normal anion gap mean? See, you will have to calculate the anion gap by the formula sodium, which is a positive charge, minus the negative charge that includes the chlorine and this chloride ion and the bicarbonate ion. Okay, you need to you will put the values of the bicarbonate here, you will put the values of chlorine here and the sodium here, and you check for the anion gap. If the anion gap is between 8 to 12, that means it is a normal gap. If it is more than 12, that means it is abnormal or increased anion gap. I told you that whenever you have a loss of bicarbonate, the chlorine always increases, and that maintains the anion gap in the patient. Okay, but if the primary defect is not the loss of bicarbonate, but the this extra addition of an acid, okay, in that case, the chlorine cannot compensate for this change, and as a result, due to this extra addition of an acid, you will be having an increased anion gap. Okay, because there is no compensation with the chlorine or anything, right? So that causes an increase in the anion gap. So in all the causes of increased anion gap metabolic acidosis, you will be having an addition of extra acid in the body. Like in case of methanol, whenever the patient drinks the methanol, they can have a formic acid in their body, and that causes the metabolic acidosis. What are the symptoms of methanol poisoning? Anyone?
Headache, nausea.
Okay, headache, nausea, that is so much common. Any other specific symptom? Because you have three drugs, methanol, ethanol, and the ethylene glycol. How you can differentiate whether a patient drank this ethanol or the ethylene glycol or the methanol? You have to differentiate between them, right? So in all the causes, you're having this high anion gap metabolic acidosis, the first thing. Because of this high anion gap metabolic acidosis, you'll be having a respiratory compensation. And the respiratory compensation is done by hyperventilation. So the breath rate of the patient must be increased. Hyperventilation, PCO2 level must be dropping. The other specific symptoms for the methanol poisoning includes the damage in your eyes, and you'll be having a blindness. Okay.
Yeah.
Okay.
So for the methanol poisoning, remember the blindness. Patient will go blind because of that. So a patient with high anion gap metabolic acidosis, hyperventilation, low level of PCO2, low level of bicarbonate, increase anion gap, and a blindness. Think about the methanol poisoning. Then second is the uremia. And please note that this uremia is not an acid. Okay, you have no acid that goes by the name uremia. It's just because of a renal failure, you cannot excrete the acid. I told you the function of kidney is to increase the reabsorption of bicarbonate and to secrete the acids, right?
Yes.
Due to kidney failure, you cannot secrete the acid. You will be having a high level of this the BUN, which is a blood urea nitrogen, uremia, and because of this uremia, you will be having a addition of the acids in your body, and that causes the high anion gap metabolic acidosis. So please note, the uremia is not a cause. Okay, it's just because of a kidney failure, you're having a uremia and plus the addition of extra acids. Okay, and those extra acids are causing the high anion gap metabolic acidosis. Then again, you're having the diabetic ketoacidosis, where you have a keto acids in your body that causes a high anion gap metabolic acidosis. Propylene glycol will cause this. Iron tablets, I told you in the previous lecture, Himang, we have discussed the acute poisoning and the chronic poisoning. Remember, in the acute poisoning, you will be having a GI bleedings. You will having a melena, the diarrhea, the bloody diarrhea, and the bloody vomiting. You will get high anion gap metabolic acidosis. You will get abdominal pain, right?
Yes.
So the iron tablets can cause this high anion gap metabolic acidosis. Lactic acidosis again, with every hypoxia, like the myocardial infarction or any case of hypoxia, whenever your body has a low oxygen in any of the tissue, the lactic acidosis will happen, and that causes a increased anion gap metabolic acidosis. Ethylene glycol, that will damage your kidneys. You will have a flank pain. You will having an acute kidney injury, and the oxalic acid stones whenever you drink the ethylene glycol along with the this high anion gap metabolic acidosis. So a patient having a high anion gap metabolic acidosis with hyperventilation, okay, with the damage in the kidney, oliguria, kidney stones, recurrent kidney stones. Think about the ethylene glycol poisoning. Salicylates, that means your aspirin, they will cause a high anion gap metabolic acidosis because they all are the acids, right? So in that case, the chloride ions did not increase in response to a decrease in the bicarbonate. And does anyone know why this bicarbonate is decreasing? Although I'm just having this addition of extra acids, I'm not interfering with my bicarbonate. So why does this bicarbonate levels are decreasing in high anion gap metabolic acidosis?
bicarb is being used as the buffer.
Yeah,
Lot of
this
bicarb.
bicarb is being used as a buffer. All these acids will combine with this bicarbonate and decreasing its concentration. But the chlorine is not increased in this response, and as a result, you'll be having a high anion gap metabolic acidosis. Is that okay?
Yes.
Yeah. Can you explain the iron tablets though?
What about the
Or-
iron tablets?
No, can you why were they giving a high ion gap? Because they pull ions away, or
It causes the addition of some extra acid. It's kind of a very much complex thing, so just you can remember them like that. Iron
okay, so
tablets.
they act as an acid. Okay.
Yeah. So, and you can remember all these acid names by the mnemonic mud pies. M for methanol, U for uremia, D for diabetic ketoacidosis, P for propylene glycol, okay, I for iron, L for lactic acidosis, E for ethylene, and S for salicylates. Okay. Now, whenever you encounter a patient with a low pH, you need to differentiate whether he is having a respiratory acidosis or a metabolic acidosis. Okay, so select one thing, either choose the PCO2 level or choose the bicarbonate. And I suggest you to go with the bicarbonate levels. Whenever you encounter the patient with the acidemia, look for the bicarbonate. If they are having a low level of bicarbonate, less than 20, that means it must be the metabolic acidosis, because low level of bicarbonate with low pH, it must be the metabolic. If you're having a high level of bicarbonate along with the acidosis, this must be the compensation, and this case must be the respiratory acidosis. So if they both goes opposite, it will be the respiratory acidosis. If they both goes in the same direction, that means it must be the metabolic acidosis. Is that okay?
Yes.
And when you got a low level of bicarbonate along with a low pH, that means the metabolic acidosis, you always need to calculate the anion gap of the patient. Looking at the anion gap, you can differentiate whether it is a high anion gap metabolic acidosis or a normal anion gap metabolic acidosis. Okay. And you also need to check whether the patient is having a compensatory respiratory alkalosis or a pathological respiratory alkalosis. Right? For that, you need to look for the Winter's equation. You will put the bicarbonate levels here and you check the level of PCO2. What could be the expected PCO2 at this bicarbonate level? Okay, if the patient is having a expected PCO2 within 1 to 2 range, that means it must be the compensatory respiratory alkalosis. If the patient is having a very highly decreased level of PCO2, okay, not anywhere near this equation, that means the patient must be having a mixed metabolic acidosis and a respiratory alkalosis. Is that okay?
Yes.
So do remember that. Any doubt on the acidemia part?
When there is a bleeding, the BUN goes up. Why is that?
Because of all these bacteria and other things, they will release a nitrogen. You will have a more absorption of nitrogen in your body, and that again causes the high level of blood urea nitrogen. Multiple
Okay.
mechanisms are there actually.
Okay. Thank you.
It's because of all these bacteria releasing the nitrogen that causes this thing.
Okay. Thank you.
Now, second, you have the alkalemia. That means you are going to have a pH of more than 7.45. Okay. Then you can again have two types, the respiratory alkalosis and the metabolic alkalosis. The pathological cause of this respiratory alkalosis is the decrease in the partial pressure of carbon dioxide. Like whenever you have a high level of carbon dioxide, it causes the acidosis. If you're having a low level of carbon dioxide, it will be causing the respiratory alkalosis. So all the causes includes the hyperventilation, like in case of panic attack, in case of anxiety, in case of hypoxemia, salicylates. I told you whenever you have an acute poisoning of the aspirin, it will stimulate the respiratory centers, right?
Yes.
So because of a stimulation of the respiratory centers, you will have a hyperventilation with the aspirin toxicity. Tumors can cause it, okay, and the pulmonary embolism can cause it, the hyperventilation, okay. So all these causes are the increasing the level of, they all are decreasing the level of partial pressure of carbon dioxide in your body. And please note, whenever you have a hyperventilation, because you're having a low level of PCO2, what's going to happen to my brain? The blood flow to the brain?
Decrease CO2 cause vasoconstriction.
Yeah, it will cause a vasoconstriction because of low level of PCO2. Remember, the blood flow in your brain depends upon the level of carbon dioxide. If you have a high level of carbon dioxide, vasodilation will occur. If you're having a low level of carbon dioxide, vasoconstriction will occur in your brain, right?
Yeah.
So as you see, whenever you have a hyperventilation, you're having a low level of carbon dioxide, and as a result, the vasoconstriction in your bloods in your brain will occur, and that causes the syncope also. So the symptoms of all these things includes the loss of consciousness because of the hyperventilation. Okay.
Yes.
So, and of course, whenever you have a respiratory alkalosis, the metabolic compensation occur. And please note, the metabolic compensation is always slow, but a respiratory compensation is always fast. Because in a respiratory compensation, you don't need to do anything but just to increase or decrease the respiratory rate. It could be done in seconds only. But for the metabolic compensation, it always takes time, like 3 days or 1 week or even a 1 month sometimes. Okay. So respiratory compensation always rapid, metabolic compensation always delayed. Okay.
Okay.
Now, in case of my respiratory alkalosis, you're going to have a metabolic alkalosis, right?
Yes.
Now you're going to have a metabolic acidosis for the respiratory alkalosis. Always opposite, right?
Yes.
So for the respiratory alkalosis, you're going to have a metabolic acidosis. In that case, my body will decrease the reabsorption of the bicarbonate. Okay. And please note, just like my acute this respiratory acidosis, in the respiratory alkalosis, for every 10 mm of Hg decrease in CO2, you're going to have a decrease in 2 milli equivalent bicarbonate for an acute compensation. For a chronic compensation, for every 10 mm of Hg decrease in the partial pressure of CO2, you're going to have a 4 milli equivalent decrease in the bicarbonate. Okay.
Okay.
See,
Yes.
this PCO2 and the bicarbonate, they always goes in the same direction. Okay. For example, in case of my respiratory acidosis, you're going to have a high level of PCO2 and as a result, a high level of bicarbonate. Okay. In case of my respiratory alkalosis, you're going to have a low level of PCO2 and as a result, low level of bicarbonate. Right. In case of my metabolic acid, in case of a metabolic acidosis, you're going to have a low level of bicarbonate and as a result, a low level of PCO2 for the compensation. Similarly, in case of a metabolic alkalosis, a high level of bicarbonate and a high level of PCO2, right?
Compensation. Yes. Yeah.
So the partial pressure of CO2 and the bicarbonate, they always goes in the same direction, no matter what the cause is, either for the compensation or for the direct or a primary pathological thing, right?
Yes.
So that's about my respiratory alkalosis. Now you have the metabolic alkalosis. In that case, you're going to have an excess bicarbonate or a acid loss. For example, whenever you have a loop diuretics, you will have an increased bicarbonate, the reabsorption, and as a result, you will be having this metabolic alkalosis. Okay, similarly, the same thing goes for thiazides also. For the vomiting, you will be having a loss of acid from your body, the HCl, and that causes an increase in the bicarbonate again. With the antacids use, the HCl will be suppressed, and you will be having a metabolic alkalosis again. Okay. In the hyperaldosteronism, you'll be having an increased reabsorption of the bicarbonate. Opposite thing happen in the this renal tubular acidosis, in which you're having a loss of bicarbonate. In case of my hyperaldosteronism, you'll be having a increased reabsorption of the bicarbonate. So in all of the causes, either you're losing the acid or you're gaining the bicarbonate. And you guys also remember the postprandial alkaline tide? Remember? Whenever you secrete the acid, the chlorine must be goes into the stomach, and in response, the bicarbonate will be exchanged in the blood, right? Let me draw this again. If this is the parietal cell, it has one pump here and one pump here. Okay. The function of this, and this is a lumen of my GIT. Okay. And this is the blood vessels, let's say. Okay. For this part, you'll be having a secretion of, yeah, the H plus will goes out, and the potassium will goes in. Remember these pumps, the potassium hydrogen pumps, the proton pump blockers will block them, will block these, right?
Yes.
So that causes an increase in the hydrogen ion in the GI lumen. Okay, you have the chlorine channels also, and they will throw out the chlorine from the cell again. Okay, so this is my chlorine. In the GI lumen, the chlorine and this hydrogen combines to form the HCl again. Okay, now this chlorine is basically extracted from the blood by the chlorine and this bicarbonate pump. Okay, the function of this pump is to influx in the chlorine and efflux out the bicarbonate. Remember, right?
Yes. Yes.
So whenever you have a high acid, you will have a high activity of these pumps, and as a result, the chlorine will be shifted inward and the bicarbonate will be secreted in the blood. So you will have a postprandial alkaline tide because of that.
Yes.
Okay.
Yes. Thank you.
It just, I want to correlate these things. It has nothing to do with this metabolic alkalosis or anything. It's just, for the correlation thing. Just remember, whenever you have a high acid in your stomach, you will always have a alkaline tide also, because you need the exchange of chlorine and the bicarbonate in the cell, right?
Yes.
So that's all the causes of my metabolic alkalosis. In my metabolic alkalosis, the primary defect is the increase in the bicarbonate, and this must be more than 28. Okay, so
Yes.
for the alkalemia, whenever you encounter a patient having a pH more than 7.45, you always need to check the bicarbonate level. If the bicarbonate levels are up, that means a primary defect is in the bicarbonate causing the alkalosis. If the bicarbonate levels are down, that means it must be the compensatory, and therefore the patient must be having a respiratory alkalosis. Because whenever you have a pH level more than 7.45, there must be a base in your body. This base either could be a bicarbonate, or this base either could be a low level of this PCO2. So one thing is sure, that the patient is having a base, and if it is not the bicarbonate, then it must be other base, right? So low level of bicarbonate with a high pH. Think about other base like this PCO2. Low level of PCO2. Okay.
Yes.
So whenever you encounter a patient for acidosis or alkalosis case, you first need to measure the pH, and as soon as you measure the pH, you need to measure the bicarbonate. If the bicarbonate are up, pH is up, metabolic. If the bicarbonate are down, pH is down, that means it must be the metabolic acidosis. If the bicarbonate and the pH goes opposite, it must be the respiratory acidosis or respiratory alkalosis accordingly. Okay. Now for the compensation, this respiratory acidosis will happen. That means the PCO2 will be decreased as a response, and this response happened very acutely. Okay, and please note, for every 10 milli equivalent increase in the bicarbonate, you will have a 7 mm of Hg increase in the PCO2. And as you can see, there is no acute or compensatory, there is no acute or chronic compensatory response, right? Because I told you it always happens very rapid, unlike in case of my this respiratory alkalosis, right? So the compensation by the lungs always happens very rapidly. So for every 10 milli equivalent increase in the bicarbonate level, you will be having a 7 mm of Hg increase in the PCO2. Remember these 3-4 equation. One equation is this. Second equation for respiratory alkalosis or acidosis, for every 10 mm of Hg increase or decrease in the CO2, you'll be having a 2 mm of Hg increase or decrease in the bicarbonate, or for the chronic 4 mm of 4 milli equivalent increase or decrease in the bicarbonate. Remember this Winter's equation, very important for the this metabolic acidosis. For the metabolic alkalosis, remember this 7 and 10 rule. Okay.
Could you repeat the 7 and 10 rule?
Whenever you have a 10 milli equivalent increase in the bicarbonate, that means a level of bicarbonate of around 34 from 20. See, the normal level of this bicarbonate is 24. Okay.
Yeah.
Normal level of bicarbonate is 24 and a normal level of PCO2 is 40. Okay,
Yes.
keep this in your mind. And the normal pH is 7.4.
Yes.
Okay, take the middle values. Whenever you have a bicarbonate of 34, that means an increase in 10, right? You will be having a 7 increase in the PCO2. That means in for a compensation, the PCO2 must be 47.
Yes.
So for every 10 milli equivalent increase in the bicarbonate, 7 millimeter of Hg increase in the partial pressure of CO2 will happen as a compensation. Okay,
Yes.
so that's it about the metabolic acidosis. Any doubt in it?
No, thank you.
Now you need to also remember this graph, understand this graph, not remember. Okay, so see, I told you you're having a pH of around 7.4 and a bicarbonate level of 24, right? Okay, in this graph on the y-axis, I'm having a plasma bicarbonate concentration, and on the x-axis, I'm having a pH. Okay, now you draw a line here, and these lines will intersect at this point. Your body in a normal patient, in a normal person, the body is working at this point. Okay, and at that line, you'll be having a PCO2 of 40 mm of Hg. Is that okay?
What is that again?
I told you normal
Yeah.
values, pH 7.4, plasma
Yes.
concentration of bicarbonate 24, and the
Yes.
PCO2 of 40. So at that
Yes.
point, you'll be having a PCO2 of 40, pH
Yes.
of 7.4, and a bicarbonate of 24. Okay.
Yeah, that will be the normal values.
Yeah, that will be the
Yes.
normal values. Now,
Yes.
let's suppose I encounter a patient having a pH value of less than 7.4. That means a case of acidosis. It could be a
Right.
respiratory acidosis. It could be a metabolic acidosis, right?
Yes.
Now I need
Yes.
to check the buffer line. Okay, if my bicarbonate levels are up or the bicarbonate levels are down. Okay, if my bicarbonate levels are down, that means it must be a case of my metabolic acidosis, right?
Yes.
Yes.
And as you can see, this graph, all these sections for my metabolic acidosis lines here is present here, right?
Yes.
It's
Now
going down
look,
with
yeah,
25.
it's going down because it is a metabolic. Now, if my bicarbonate levels are up along with the acidosis, that means it must be a case of my respiratory acidosis, right? And as you can see, the bicarbonate levels are up here.
And the O2 also we can say it's going up.
Yeah, exactly. The O2,
CO2.
the PCO2's level is going up,
Yes.
right? So now see, this is your buffer line, or you can say the line of your the bicarbonate. Okay, as you can see, is going upward, right?
Right.
So you're having a pH of less than 7.4, but the bicarbonate levels are increasing, right? And this is the respiratory acidosis with a compensation in the bicarbonate, with the
Right.
metabolic compensation. Now,
Yes.
look at this point. This line represents the partial pressure of your CO2. And at that point, the PCO2 is 40. And on this line, sorry, on this line, on all of this line, you'll be having a PCO2 level of 40. Whenever you have a low pH along with a low bicarbonate level, okay, you always gonna have a compensation of respiration, right? That the change in level of PCO2, or you can say a decrease in the level of PCO2, right? So as you can see, whenever you have a low level of pH, okay, along with a low level of bicarbonate, you always gonna have a shifting of this curve downwards. And whenever this curve shifts downward, the partial pressure of this CO2 always decreases. And whenever the curve shifts upward, the partial pressure of the CO2 always increases. Is that okay? Are you getting my point? On all of this line, the PCO2 level is 40. Okay. So if I shift this line downwards, this partial pressure will decrease And if I shift this line upward, the partial pressure will increase. On this point here, the partial pressure could be 50, let's say.
Yes.
And on this
Okay.
line downwards and all of this line, the partial pressure could be 30, let's say.
Decreasing, right?
Okay. So that
Yeah.
represents a compensation thing.
Right.
Yes.
Now, if I have a metabolic acidosis, that means a low pH along with a low bicarbonate level, this line must be shifting downwards. And as you can see, if this line shifts anywhere in this quadrant, it will always be a compensation, right?
Compensatory,
As you
right?
can see. And if this line shifted upwards, then it means it is a pathological acidosis.
Okay. Yes.
Okay.
Yes.
Are you getting my point?
Yes.
So
Means
that means,
acidosis is there, but CO2 is going to be increased. That is the pathological.
yeah, exactly. Although you are having an acidosis in your body, metabolic
Okay.
acidosis, for that you must be having a respiratory compensation. That means alkalosis, respiratory alkalosis, right? The PO2 should be going downward. But instead, the PCO2 level is rising, as you can see. That means it must be a case of mixed metabolic acidosis as well as the respiratory
Yes.
acidosis.
Okay.
And
Yes.
that's what the FA says here, a mixed acidosis.
Okay.
Yes.
Okay. Now, the second thing again, if you're having a respiratory acidosis, that means at this case, in this scenario, you will be having a PCO2 level more than 40. Okay. More than 40. That means at this line. Okay, let's say. For this scenario, the bicarbonate must be increasing as a compensation. This line will go up like in this direction.
Yes.
Okay. This line always go in this direction. So how the step one gonna present you a question? They will give you this kind of a graph. Okay. Like the CO2 levels and the bicarbonate levels. Okay. And they will describe you a patient having a PCO2 level of, say, this line represent a PCO2 level of 50, for example. If this line represent a PCO2 level of 50, and let's suppose this is a case of my respiratory acidosis, for example, what could be the pH? It must be less than 7.4, right?
Yes.
Yes.
So this must be, let's say, 7.3, for example. Okay. Now the step one will ask you what gonna happen to this bicarbonate line if it is a compensation case. So they will describe you these kind of arrows as option B, option A, option C, option D, and they will ask you where does this line must go. So it must be going upward for a compensation.
Yeah, increase reabsorption.
And if it is a mixed case, okay, they will give you some, some drug case maybe, in which you're having a mixed acidosis. In that case, they will ask you where does this line must be going. It must be going downwards.
Yes. Yes.
Okay.
So these kind of questions could be presented with this graph. Okay. So for that, you must understand what's happening in this graph. This line represents a partial pressure of CO2, and this line representing a bicarbonate levels. Okay. Shifting of this line upward will increase the bicarbonate level. Shifting of this line downwards will decrease the bicarbonate level. Shifting of this line towards the this left side will increase the partial pressure of CO2, and going this line towards the right side will decrease the partial pressure of CO2. Okay.
Right.
Now comes the case of alkalosis. You're having an alkalosis. It could be a metabolic, it could be a respiratory. For the metabolic alkalosis, you must be having a high level of bicarbonate, right?
Yes.
So this line must be shifting upwards like here, for example. Instead of a normal person who is working on this line, this patient is working on this line, increased, as you can say. Right?
Yes.
Right.
Now, and initially the patient is working on a pH of 7.5. Now see, I need to have a respiratory compensation. For that, this line must be going in this direction. And see, if this line goes in this direction, I can again have a normal pH.
Yes.
Yes.
Yes, that's a compensatory.
Similarly, let's say it is a case of this respiratory alkalosis. For that, my line must be shifting downwards. In a normal patient, if my PCO2, a normal patient is working at that point, but my patient is now started working at that point. Okay, that means a pH of around 7.6 or 7.7 because of a decrease in the partial pressure of CO2. Okay, now I must have a metabolic compensation, and that could be done by decreasing the level of my bicarbonate, right? For an acute compensation, I can have a line at here, acute compensation, and as you can see, the pH is slightly improved towards a normal. For the chronic compensation, the line must be decreasing more downwards. And as you can see, now the patient is started working at that point. So this is the acute compensation. This is the chronic compensation. Right?
Yes.
So this lines
Yes.
must be shifting downwards. So by giving this kind of a scenario, they will give you a patient pH values. They will give you a partial pressure value. For example, the patient is having a partial pressure of, let's say, 30 or 20, for example, 20, let's say. So the patient is having a partial pressure of 20. That means a case of respiratory alkalosis. And now they want to ask you by giving you this kind of a graph, whether it is an acute compensation or a chronic compensation. So look, for every 10 mm of increase in CO2, decrease in CO2, the levels of bicarbonate must be decreased by 2 for acute compensation, right? And here the patient is having a decrease of 20. That means for an acute compensation, the bicarbonate must be falling for 4, right? Okay, as you can see. So now look for the bicarbonate levels here on this line. If the bicarbonate level is decreasing by 4, that means it is the acute compensation. As you can see, it is 25 to 20, right? For example, so it is an acute compensation. Then say a chronic compensation, the bicarbonate might be decreased by 8, right?
Right.
You're having a bicarbonate level of around 15 or 16, 17, for example, right? So this must be the chronic compensation. So by giving the graph, they can ask you whether it is an acute compensation or a chronic compensation or at a compensation at all. Okay, it could be a mixed case also. For example, if the bicarbonate level, instead of going down, they increased, for example, like here, the patient further have a more alkalosis, right? And it will be a mixed alkalosis. So they will ask you whether it is a compensation or a pathological response. So look for these equations, look the level of bicarbonate on this graph or a level of PCO2 on the graph. And that's how you know whether it is a compensation or whether it is a pathological response, okay? They can give you a scenario and they will ask you if this is a compensation, where does this line must be going, upwards or downwards? Okay.
Okay.
Right.
So these kind of questions would be framed on this graph. So for that, you must understand this. Okay, PCO2 level going on the left side, it will be increasing. Right side, it will be decreasing. Bicarbonate line going upward will be increasing, downward will be decreasing. So, any doubt on this acidosis and alkalosis?
No, thank you.
Okay, so that's all on this page. Okay, now you have the renal tubular acidosis, and as the name suggests, in all of these causes, like I've discussed previously also, and all of these causes, you're having a loss of bicarbonate from the body, and that causing a normal anion gap metabolic acidosis. Okay. So in actual, you're having a alkalosis of the tubules and the acidosis of the body. Okay. Alkalosis of the tubules, the renal tubules, and the acidosis of the body.
Okay.
See,
why it's alkalosis in the tubules?
Because you are losing the bicarbonates in the tubules, right? And if you're losing the bicarbonates in the tubule, the pH of the tubules must be increasing, right?
Okay, so I mean in the tubule, the secreted fluid.
Yeah, exactly. You know, in
Okay.
all of these causes, you're losing the bicarbonate in the tubules. And if the bicarbonates are getting lost in the tubules, that means they will increase the pH of my tubules because of that, right?
Yes.
Okay.
So in all of the causes, I'm having an increased pH of the tubules and a decreased pH of the body, because ultimately you're losing the bicarbonate from the body, right? The first one is the distal
Yes.
renal tubular acidosis. And as the name suggests, it is a problem with a distal part in the nephron. And the problem lies with the alpha intercalated cells. Okay, I told you in the alpha intercalated cells, you have some pumps that will secrete the bicarbonate. Okay, and absorb the that will secrete these cells will secrete the H plus via the pumps, and these cells will also increase the reabsorption of the bicarbonate. If the cells become dysfunctioning, okay, in that case, you cannot secrete the bicarbonate. You cannot secrete the H plus in the tubules.
Yes.
Okay, and as a result, you cannot generate the bicarbonate, so you'll be having a metabolic acidosis, right? Because you know, if you look for the reaction, if this is my sorry, if this is my collecting duct, you're having the tubular cells here. Okay, and this is the alpha intercalated cells. Just like my PCT, in the alpha intercalated cells, you have the carbonic anhydrase. Remember, this is your bicarbonate at CO3. It will combine with this H plus, okay,
Yeah.
that is secreted by these pumps from the cells, right? It will combine to form this carbonic this acid, okay, at CO3, H2CO3, and then with the help of carbonic anhydrase, it will be converted into the CO2 and H2O. Remember,
Yes.
Yes.
CO2 will be diffused in, again, combine with this water, forming a bicarbonic this carbonic acid in my cell. Again, this carbonic acid will be converted into the bicarbonate and the H plus, right? And the bicarbonate getting absorbed in the collecting duct, right?
Yes,
And this
yes.
H plus again going out of the cells. So if the pump is not working, if the alpha integrated cells cannot secrete this H plus, then it cannot absorb the bicarbonate, right?
Right.
And as
So
a result,
H
you'll
plus.
be having as a result, you'll be having a loss of bicarbonate in the tubules, and you'll be having a metabolic acidosis. Is that okay?
Yes. Okay.
So you will be having a alkaline, you'll be having this alkaline urine. Okay, you will be having also along with that, because you know you have the hydrogen potassium pumps. Remember, that will cause the reabsorption of the potassium and a secretion of hydrogen,
Yes. Yes.
because the hydrogen cannot be secreted, so you cannot absorb the potassium either.
Yes.
And as a result, you also loses the potassium in the cell, in the tubules. So a low level of potassiums are also found. In all of these causes, you're having a normal and uncapped metabolic acidosis, of course. In case of my distal renal tubular acidosis, you also having a loss of potassium. So a low bicarbonate, low pH, low potassium. Think about the distal renal tubular acidosis. Okay.
Yes. Distal means and the collection duct.
Yeah, distal means a collecting duct.
Thank you.
Now you have the causes, and these are the amphotericin B. Analgesic toxicities can do that. Nephropathy, analgesic nephropathies can do that. Congenital anomalies can do that. Okay. Any autoimmune conditions like the SLE can also do that. Okay. So, you know, just remember this amphotericin B. This is a very important one that can cause the distal renal tubular acidosis. This is the important one. Okay. Now, it will increase the risk of developing the calcium phosphate stone, because you need the alkaline pH in your tubules to form the calcium phosphate stones in the kidney. Okay. And because you're losing the calcium, okay, you will be and you're having an acidosis in the body. I told you that these osteoblast cells require the basic medium, and the osteoclast cells requires the acidic medium for their function, right? go back to the MSK, I told you that the osteoclast cells require the acidic medium and the osteoblast cells require the basic medium,
Yes. Yes.
right? So because you're having a very acidosis, it will increase the bone turnover. The resorption
Yes.
of the bone is also increased. Okay, and you will get again the bone pain will be there. Okay, osteoporosis you will get, fractures you will get. Okay, so these things will happen. A loss of calcium, loss of formation of a calcium phosphate stones in the kidney, increasing in the bone turnover, so that you will be having a this bone pain and osteoporosis. These are all the symptoms of the distal renal tubular acidosis. Any doubt?
There will be hypercalcemia.
There will be
Hypercalcemia.
no. There
Calcium in
won't
the
be any
blood.
hypercalcemia. No, there won't be any
No.
hypercalcemia.
Yeah, bone turnover will not release the calcium.
It will increase, but again you're having an increased secretion of all this calcium from the kidneys at the same time, right?
Okay.
So that will maintain the normal calcium level, and you're having all these stones also, right? All this phosphate will combine with the calcium to forming the stones, right?
Yes.
The second one is the proximal renal tubular acidosis, and it is a type 2. In this case, you're having a defect in the proximal convoluted tubule. Remember the Fanconi syndrome? We are having a loss of all these electrolytes and the bicarbonate from the PCT.
Yes.
Same thing is going to happen in this defect. You're having a decrease in the reabsorption of the bicarbonate. As a result, you will be having a loss of this bicarbonate from the these tubules in the urine, right? So you're having a metabolic acidosis because the alpha intercalated cells are normal in this case, so they will try to compensate it by increasing the reabsorption of the bicarbonate in the collecting duct. But you know that almost 60% of the bicarbonate, 60-70% of the bicarbonate got reabsorbed in the PCT, right? 70%.
Yes.
So no matter how much the alpha intercalated cells try to compensate, they cannot overcome the excretion or the loss of bicarbonate, right?
Yes.
So ultimately, you'll be depleting the bicarbonate level. And I told you, for a ultrafiltration, you need to have a level of this, for the filter load, you need to have a plasma concentration of the solute, right? The filter load will be equal to GFR times the plasma concentration of that substance. Remember the filter load,
Yes.
GFR times the plasma concentration of that substance.
Yes.
So now you can see, if I'm increasing the excretion of my bicarbonate, then ultimately the level of this bicarbonate will decrease in my body. The plasma concentration of my bicarbonate will decrease, right?
Yes.
In that case, I cannot have any filter load of bicarbonate after some time.
Yes.
So in my this proximal renal tubular acidosis, initially I will have the alkalization of the urine, okay, increase in pH of my tubules, alkalosis of my tubules. But soon, when all of the bicarbonate got depleted from my body, I will be having the acidosis of both my tubules as well as my body. Okay.
Yes.
Causes includes the Fanconi syndrome and all the causes of the Fanconi syndromes like the multiple myeloma, carbonic anhydrase inhibitors therapy. Okay, because you know that they will inhibit the carbonic anhydrase like the acetazolamide, dorzolamide. They will inhibit the reabsorption of the bicarbonate in the PCT, right? So carbonic anhydrase inhibitors can cause the proximal renal tubular acidosis type 2. Okay.
Yes.
Again, you will be having an increased bone turnover. You will be having a hypophosphatemic rickets. Because again, in case of a Fanconi syndrome, you cannot absorb anything, right? No calcium, no phosphate, nothing. So in Fanconi syndrome, you will be having a risk of hypophosphatemic rickets. Is that okay?
Yes.
Yes.
So that's about the proximal renal tubular acidosis. In my type 4 renal tubular acidosis, you're having a hypoaldosteronism. Causes includes, of course, a decreased production of the this aldosterone, like the diabetic hyporenism. Okay, in case of this, you're having a low level of renin, because in case of my diabetes, I'm having a too much of the this volume of the water in my body, right? And having a hyperosmolarity. So all of these, the renin and this ADH got suppressed, And as a result, I will be having a low level of aldosterone in my diabetes, right?
Yes.
So the diabetic hyporenism, okay, ACE inhibitors therapy, ARBs therapy, NSAIDs can do that, okay, heparin therapy can do that, cyclosporin, adrenal insufficiency can do that, Addison's disease, you call it, okay. For the resistance, the potassium-sparing diuretics like the spironolactone, aplepanone can do that, okay. Nephropathies due to any obstruction can cause it, okay. So ultimately, all of the causes, including the low level of aldosterone or inhibition of the receptors of the aldosterone, okay. And symptoms will be similar to that of potassium-sparing diuretics. You'll be having a high level of all these what do you call it, the potassium, hyperkalemia you will get, okay, metabolic acidosis you will get, urine alkalization you will get, stones you will get, okay. So yeah, that would be this. And because you're already having so much bicarbonate in your kidney cannot excrete the this ammonia, right? And as a result, you'll be having a low level of excretion of the ammonia. You will be having a hyperammonia also in your body, okay.
Okay.
So that's everything about the renal tubular acidosis. A very easy topic. Just know for the type 1 or a distal type, you will be having this loss of all these alpha integrated cells or dysfunction of the alpha disintegrated cells. In a type 2 or the proximal type, you're having a loss of bicarbonate because of loss of absorption of this bicarbonate in the PCT. Okay, then in a 4 type, in the hyperkalemic tubular acidosis, you're having a hypoaldosteronism, right?
For
Yes.
aldosterone resistance.
Any doubt, please ask.
How is diabetes causing hypoaldosteronism?
Please repeat it again.
How is diabetes causing type 4?
See, in case of my diabetes, I'm having a hyperosmolarity. Okay, I'm very too much fluid in my body, right?
Yes.
And the renin needs to increase the fluid, right? This function of renin is to increase the fluid in my body, right? But if I'm
Okay.
already having a too much fluid, then why I need the renin at all? I don't need the renin.
No.
So that will suppress the renin, and as a result, you'll be having a loss of aldosterone also.
Okay, I understand.
Yeah. So that's about all these things. Any more doubt?
Oh, thanks.
So let's take a short break and then discuss all the renal changes with the aging. Okay.
Yes, thank you.
Okay. Okay. One is the decrease in the renal mass and the functions of the glomeruli. Okay. Second is the decrease in the renal plasma flow. And third is a decrease in the hormonal response. Okay. So now see, with the aging, all of the functional glomeruli is gonna go decrease. Okay, you're gonna have an atrophy of the kidney, right? And because of that atrophy, you're gonna have the fibrosis and a decrease in the mass of the kidney or size in the kidney, right? But please note, that the serum creatinine level, it always remains normal. Although the number of functioning glomeruli are decreasing, the clearance of the creatinine is decreasing, GFR is also decreasing. But even then, the serum creatinine levels is always remains normal. Can anyone tell me why is that so?
You're losing muscle mass as you get older?
Yeah, because you're losing the muscle mass also as you get older. And I told you that creatinine is nothing but a waste product of your muscle. The creatinine, right? The creatine kinase, remember?
Yes.
Yes,
Creatine
yes.
and creatine kinase. And the waste product is a creatinine, right? So ultimately, if you decreases the muscle mass, then you will have a less creatinine. So your kidney requires a less excretion of the creatinine also, right? So even though you're having a decreased clearance of the creatinine, a decrease in the GFR, but you will have a normal serum creatinine value. So if you encounter a patient who is having a falling in the GFR, you can think it like it may be a case of kidney failure. But when you look for the serum creatinine levels, you see that the patient is having an absolutely normal serum creatinine. And that means the kidney changes is all due to the aging, not a pathological. Okay. The patient's ability to concentrate the urine also get decreased. And that's why he will have a loss of free volume of water that can predispose the patient to developing the hypovolemia at the time of stress. And because the clearance and the GFR of your kidney is decreasing, and that's why the clearance of various drugs is also decreased in the old age, and that's why you need a um, less amount of drug in the person, right?
Yes.
Then you have a decrease in the renal plasma flow because of this thing. So the kidney will become very susceptible to the ischemic injury in the old age. Okay, and I told you that you require the prostaglandin to increase the renal plasma flow, right?
Yes.
And because you're already decreasing the blood flow to the kidney in old age, you need those prostaglandins to maintain the kidney function. If you use the NSAIDs in the old age, that can lead to a renal injury also. Hormonal response in response to the renin or the PTH is also get decreased, you will see. Okay, but the ability to excrete the solutes is always reserved, normal. It always be normal. Okay, it is always preserved. You will have a decreased clearance, decreased GFR, okay, decreased clearance of all these things, renal plasma flow decrease, hormone response decrease, but the ability to excrete the solutes is always normal. Okay.
Yes.
So that's all the changes you will see in the old age. And when you do the biopsy, you will find the atrophy of the cells and the fibrosis. Okay. And yeah, that would be all on this page. Any doubt, please ask. Yeah.
No, thank you.
So we are done with the anatomy, physiology, and the embryology of the kidney. And now let's start the pathology. So for first, you need to know about all the cast that you find in the urine. Okay. And whenever you find these cast, that means something is going on with your kidney. And specifically telling about your tubules, something is going on with your tubules. Okay. So a presence of cast indicates a hematuria. It could be a pyuria, it could be a glomerular or a renal tubular injury. It must be. Okay. Whenever you have a damage below the kidney, that means, like in case of a bladder, you can have a hematuria also in the bladder, like in case of this pyelonephritis, but you cannot have the cast in it. With the kidney stone, that those stones which are found in the ureters or or, or this tract. Okay, so anything below the kidney, any damage, okay, that happens below the kidney, it can cause the hematuria, but no cast. If the damage happens to the kidney, that can cause the hematuria as well as the cast. So a presence of cast always indicate a renal pathology. Okay, in case of acute cystitis, you can have a pyuria, but you cannot have the cast. Okay, so first you have this RBC cast. Okay, and whenever you find the cast of RBCs, okay, you will think about the glomerulonephritis or the hypertensive emergency. Because I told you, in a hypertensive urgency, you do not have any kind of a damage, remember? Just the high BP is present. In case of hypertensive emergency, you're going to have the high blood pressure as well as the end organ damage.
Yes.
Right? So the end organ damage will damage your tubules, and that can cause this kind of a cast formation, the RBC cast. Okay. Second, you have is a WBC cast. And whenever you have a WBC cast, you will always think about an inflammation. Okay, it always be a tubular inflammation or a glomerular inflammation. So that can happen with the tubo-interstitial inflammation, acute pyelonephritis, and the case of transplant rejection. Okay. Third, you have is this granular cast. And whenever you see the granular cast, which is muddy brown in color, as you can see, you will always think about the acute tubular necrosis. It's a very highly characteristic feature of the ATN. You will always have a granular cast in it. So it is kind of a pathognomonic for the ATN, okay? Third, you have this the fatty cast or the oval cast, and it's seen with the nephrotic syndrome because of too much production of the all these lipids by the liver. Okay, you're gonna have a oval fatty cast. As you can see, it will be appear as these kind of a cross-like structures. You call them the Maltese cross sign. Then you have a waxy cast, and waxy cast, whenever you hear this word, you will always think about the end stage renal disease or a chronic kidney disease. With every patient having a kidney failure, they always have this waxy cast. Okay, this waxy cast is also seen with one more cancer, if anyone remember. In the hematology oncology part, we have discussed a cancer where you find the waxy cast in the urine.
Basal cell.
Not the basal cell.
Multiple
It was a multiple
myeloma.
myeloma. Multiple myeloma, yes. Please note that the multiple myeloma, you're gonna have a damage in the kidney, right?
Yes.
Yes.
So in the multiple myeloma, you can have a waxy cast also. Okay, do remember that
Okay.
waxy cast. Then you have a hyaline cast, and it is generally a normal finding. Okay, what happens normally, you do not find this hyaline cast, but whenever you have a concentrated urine, like in case of a dehydration or any case of a pre-renal azotemia, you will always find the hyaline cast. Okay, it is non-specific. It is could be a normal finding. Okay, it happens because of some TAM hostile mucoproteins, and I told you normally some kind of proteins got filtered in the GFR, right, because of their small charge and small size. Remember?
Yes.
They could also be secreted sometimes in a very small amount, and these forms are TAM hostile mucoproteins. These mucoproteins, right? And please note, you will always find them whenever you have a dehydration or any increased concentrated urine. You will always find this. So okay, so it could be a normal finding also, or you can find them with any case of pre-renal azotemia. Is that okay? You can write it down here. With any case of this pre-renal azotemia, you can have the hyaline cast in the kidney. Okay.
Okay.
Then some nomenclature, and whenever you see the focal, for example, the focal segmental glomerulosclerosis, it is always involving less than 50% of the glomeruli. Okay. If it is diffuse, that means involving more than 50% of the glomeruli. For example, the DPGN, proliferative, that means you're going to have a proliferation of the glomeruli. Hypercellularity will be C. For example, the membranoproliferative glomerulonephritis. Membranous, it is always localized to the membrane only. You will have a thickening of the membrane. Okay, so in the proliferative glomerulonephritis, you're going to have a proliferation of all the structures in the glomeruli. In case of a membranous, you're going to have just the thickening of membrane. So also you will find it in the membranous nephropathy. We will discuss all of these diseases shortly. In the primary glomerular disease, that means the pathology involving the kidney first. Okay, it is specifically impacting the glomeruli of the kidney. For example, the minimal change disease, you're going to have some formation of cytokines or the antibodies against the glomeruli specifically. Okay. Secondary glomerular disease, in that case, some autoimmune reactions happen to other tissues that are also affecting the kidney. For example, the SLE, you are going to have a multiple formation of this, all these immune complexes, and when the immune complexes, they actually form from, form for other antigens, right? But then they're depositing on the kidney, causing all the kidney damage. So it is a secondary kidney damage because of any other disease. Okay, like a diabetic diabetic nephropathy, for example. Okay, diabetes is a other system disease, but the kidney is getting affected because of it. So it is a secondary glomerular disease. And out on this page.
No, thanks.
No, thank you.
Okay, then you have, first let's discuss all the glomerular diseases. In all of the diseases, you're going to have a damage in the glomeruli. And I told you about this filtration barrier. First, you have the endothelium, then you have the basement membrane, and then you have the podocytes towards the epithelium surface, right? So endothelium, basement membrane, and the epithelium, right? You call it a nephrotic syndrome. We call it a nephrotic syndrome. You call it a nephritic syndrome whenever you have an inflammation of the glomeruli, in all of the causes of the nephrotic syndrome, you will be having an inflammation. And because of that inflammation, you will be having a damage in this filtration barrier. And as a result, the inflammatory cells, RBCs specifically, they will get filtered in the ultrafiltration and they will appear in the urine also. They will form a cast and they will, and so that you will always see a RBC cast in it. Okay, so because of the glomerular inflammation, you're going to have a glomerular basement membrane damage, and that causes a loss of RBCs and WBCs in the urine. You're going to have a hematuria. Okay, so the clinical presentation will be the hematuria first. You will be having a RBC cast in the urine. Okay, now all these RBC filtration will block the filtration again. Okay, and because of this filtration blockage, you're going to have a decrease in the GFR. And because of this decrease in the GFR, you will have a edema, you will have a high BU and creatinine ratio, you'll be having the oliguria, azotemia will occur. That means a high BUN level. And because of this azotemia, because of this kidney failure, because this loss of GFR means a kidney failure, right?
Yeah.
Yes.
So because of this kidney failure, you're going to have a BUN and other uremia also. Okay, some acids will deposit in your body and causing a high metabolic acidosis. Okay, renin will be released because of this fallen GFR. You will have a loss of sodium delivery also. Renin will get activated, RAS system. You will be having a hypertension because of it. Proteinuria will also occur in nephrotic syndrome, but it's often in the subnephrotic range, which means a less than 3.5, or you can say a 2+ protein level only. While in case of nephrotic syndrome, you're going to have a 5+ protein. So 1 or 2+ protein level always suggestive of a nephrotic syndrome. Okay, you will have a localized edema also because of this protein loss. Okay, examples include the acute this APGN, acute post-streptococcal glomerulonephritis, RPGN, IgA nephropathy, Alport syndrome, and the membranoproliferative glomerulonephritis. So in all of the nephrotic syndrome, you will having an inflammation first. Okay, then you have some mixed disorders also. For example, the membranoproliferative glomerulonephritis is a mixed. This condition is kind of a mixed type. In this case, you will having a mix between the nephrotic and the nephrotic syndrome. So both the inflammation as well as a heavy proteinuria will be present in the MPGN. Okay, in this case, you'll be having because it is a membranoproliferative, right? So you'll be having a proliferation of the membrane, thickening of the membrane, we'll see, right?
Yes.
And the third kind is of nephrotic syndrome. In case of nephrotic syndrome, the damage is happening in the podocytes. And I told you the podocytes having a negative charge, it will repel the proteins, right?
Mm-hmm. Yeah.
Because of this loss of negative charge, now proteins start getting filtering in the ultrafiltrate, and by this GFR, you will be having a proteinuria. Okay, please note no inflammation or a very slight inflammation in some cases, which we will discuss later. But in most of the cases of nephrotic syndrome, you won't have an inflammation. It's just you're having a damage in the podocytes that is causing a proteinuria. A massive proteinuria, 5+ protein will be seen, which is more than 3.5 grams per day. Because of this loss of protein, you will be having a hypoalbuminemia. And I told you that these albumin levels are required to maintain the oncotic pressure, right?
Yes.
Yes.
Now, because you're losing all this albumin, you cannot maintain the oncotic pressure, and now you will have the edema. Okay, because of the presence of these proteins and fats, you will be having a frothy urine. Because of this loss of protein, your liver will try to compensate, and when it try to compensate, then along with the protein synthesis, liver also synthesize the fats, the lipoproteins, right? So the fat count, all this lipid level in your body will also increase in the nephrotic syndrome, and that causes the fatty cast. Remember the Maltese cross, previous page?
Yes. Yes.
That you will see in the nephrotic syndrome. Okay, because of loss of protein, you will have a loss of antithrombin 3. And whenever you lost the antithrombin 3, you will be having a hypercoagulable state. Patient can have a recurrent episodes of renal infarction, and that will present you with the flank pain and this hematuria. LDH count will increase. I told you LDH is a marker of cell destruction, right?
Yes.
Lactate dehydrogenase.
Yes, yes.
LDH is a marker of cell, yeah, right? So LDH will increase, flank pain will occur, hematuria will occur, new hematuria, right? Okay, multiple episodes of deep vein thrombosis. Okay, all of these things will happen because of loss of antithrombin 3, because of loss of antibodies. I told you in multiple myeloma that in multiple myeloma you only have a Ig light chains, right? No complete antibody. If you're having a complete antibody in the urine, that means you're having a nephrotic syndrome. So because of this complete loss of antibody, okay, you will be having an increased risk of infection also. Okay.
Okay.
Yes.
The causes include subfocal segmental glomerulosclerosis, minimal change disease, membranous nephropathy, amyloidosis, and a diabetic glomerulonephropathy, which we will discuss shortly in the next pages. Okay.
Yes.
So that's about the nephrotic syndrome, and in between my nephrotic syndrome, in which you're having a severe loss of the membrane. Okay, you will be having a loss of RBCs, as well as because of damage in the charge barrier, you will be having a hematuria along with the proteinuria. It could be a DPGN or the MPGN, two types. So any doubt on this glomerular diseases?
No, thank you.
And please note, because the podocytes are absolutely normal or very slightly damaged in case of nephrotic syndrome. So that's why you have a very mild proteinuria only. Okay, because you know the most important thing to prevent the protein filtration is a negative charge. Okay, so in the nephrotic syndrome, you have a very mild proteinuria. In nephrotic syndrome, podocytes got completely damaged. So a massive proteinuria. So now let's discuss all the nephrotic syndrome. Okay, and please note it is always an inflammatory process. You will be having an inflammation of the glomeruli, and because you're having the inflammation of the glomeruli, whenever you do the biopsy of the patient, you always find the hypercellularity of the glomeruli. Okay,
Yes.
so the first one is the acute post-streptococcal glomerulonephritis, and that happens because of a previous infection by the Streptococcus pyogenes, the group A streptococci. Okay, when the antibodies are formed against this group A streptococci, okay, they will form some immune complexes, and when the infection got over, these immune complexes will start depositing on your kidney, on this glomerulus, right? They will form immune complexes there, and as a result, because whenever you have a deposition of the immune complexes, it will attract the neutrophils, right?
Yes.
So it will attract the neutrophils, and whenever the neutrophils arrive, they will cause the inflammation. So that's why in the APGN you're gonna have an inflammation because of the deposition of immune complexes. It always seen 2 to 4 weeks after the group A streptococcal infection. Please note that timeline. It is always a patient having a infection a month before, and when the infection got over, after a month, patient started having this kidney symptoms. Okay. And please note, infection could be of pharynx or could be of skin. Like I told you, in case of when the infection of the pharynx happen, and that is the pharyngitis, you can have a heart disease. Does anyone remember?
Yeah, rheumatic fever.
Rheumatic.
Infective
The rheumatic
endocarditis.
fever, right? Yeah, endocarditis. Yeah, this rheumatic fever, right? So with the
Yeah.
pharyngitis only, you can have a rheumatic fever, but with both the pharyngitis as well as the skin, that means the impetigo, it can cause the APGN. Okay, do note this fact also. So it is always spontaneously resolves on its own, no need for antibiotic at all. Okay, and because it is causing this inflammation in the kidney, it is basically damaging your glomeruli, right? It is damaging your nephrons. So ultimately, the kidney will become dysfunctionable, right?
Yes.
And because the kidney got dysfunctionable, you'll be having a high GFR. Sorry, you'll be having a fall in the GFR. Edema will happen, hypertension will happen, hematuria will happen, right? So all the patients acutely present with the renal insufficiency. Especially in case of adults, it causes a severe type of APGN, okay, and it can cause the chronic kidney disease in case of adults, it will always progress to the kidney failure in case of adults. That is an important thing. It is a type 3 hypersensitivity reaction versus my rheumatic fever, which is a type 2 hypersensitivity reaction. Okay, patient will always present you with the periorbital edema, and that is the most important first symptom of the patient. The periorbital edema, they will have a swelling around their eyes. Tea or cola colored, or you can say a very dark urine will present. Hypertension will be there. Fall in GFR will be there. And then, when you suspect that this could happen, you will perform the titer of the patient for a previous infection of my group A streptococci. Okay, you will check for the anti-DNase antibody. Okay, you will check for the anti-streptolysin O antibody. And when you have a positive anti-DNase and anti-streptokinase antibody, anti-streptolysin O antibody, when you got them positive, you will immediately know that the patient is having a APGN, right? And because of this immune complexes, the complements will also form the immune complexes. Because I told you that if you go back to the previous lectures, we have discussed about how this IgG and IgM fixes the complements, right?
Yes.
So due to the formation of IgG and IgM immune complexes, they will fixes the complement, and because of this complement fixation, you will be having a low level of complement C3. Remember the three
C4
rules
also.
for the
And C4
yeah,
also.
C4 also. Yeah, C4 also. Both the C3 and C4, but mainly it is C3. Okay.
Yeah.
And I told you about 3 ways by which you can fix the complements. And does anyone remember from the immunology?
Alternative, classical, and the
Classical. One is classical. Other one is
alternative,
alternative, and
manos
classical,
binding.
alternative, and Manos binding. Yes, exactly. Classical, Manos binding, and the alternative pathway. And through which pathways these IgG and IgM fixes the complement?
This is C3 binding. So
Alternative or classical pathway?
Classical pathway.
Yeah, exactly. It is a classical pathway through which these IgG and IgM fixes the complements. Okay, so you got a patient picture now, a patient who is very teenage, a very little child. Okay, and now he's present in your emergency department with this periorbital swelling, having a hypertension, hematuria, oliguria, edema, low GFR. Okay, you think about that this could be a case of APGN, so you run the test. Okay, you do the strep titers, anti-streptolysin O, anti-DNase antibody titer. You found it positive. You check for the complements level. You see that the complement is dropping, the level of C3 mainly, and some C4 is also dropping. Okay, then you decided to do the biopsy of the patient. Okay, in the biopsy, you look for the, once you do the biopsy, you do this in the H&E staining, and in the H&E staining, you look in the light microscopy. Okay, in the light microscopy, you will see the hypercellular glomeruli, because I told you it is an inflammatory condition. Neutrophils will be there, other cells will be there, inflammatory cells, and that will cause the hypercellularity of the glomeruli, right? So you will be having an enlarged glomeruli as well as a hypercellularity there. Okay. As you
wait,
can
why
see,
are we having the hypercellularity?
we have what?
The hypercellularity, is that the nephron themselves, or is it the
Inflammatory cells and nephrons all, because whenever you have an inflammation, because it is
Okay.
acute inflammation, it is always because of WBCs mainly.
Okay, thank
In
you.
the chronic type, you can have both the this nephron and as well as this these cells also, inflammatory cells also, both in chronic. But in case of acute, it is always the inflammatory cells. Okay. So as you can
Okay.
see, all these inflammatory cells are present in the nephrons, right? Okay, so this kind of a hypercellularity you will see in the glomerulonephritis, and because it is an inflammatory condition, you will also have the edema of the glomeruli, right?
Yes.
So enlarged glomeruli will be seen. Okay. So enlargement of the glomeruli and the hypercellularity will be seen on the light microscopy. Then you decided to run for the, you check for the antibody deposition. Okay. And you do the immunofluorescence against the IgG, IgM, and the C3 complements. And guess what you are found? You will find the lumpy, bumpy appearance, because all these immune complexes will be depositing towards the epithelium side and as well as towards the endothelium side, mainly towards the endothelium side. Okay. Oh, sorry. Mainly towards the epithelium side. So what you will find? You will
Subendothelial,
find
basically. Antibody
yeah,
deposition is subendothelial
subepithelial,
deposition.
subepithelial actually, towards the epithelium side. Okay. So what
Isn't
you will
it
see, because of
subendothelial?
see, in case of nephrotic syndrome, it is epithelial, subepithelial.
Okay. Okay.
Okay, but in case of my nephrotic syndrome, actually see, it depends upon the pathology. In case of my this APGN, it would be subepithelial. In case of my rapidly progressive time, it could be epithelial or endothelium. Similarly, in case of my DPGN, it could be endothelial or it could be epithelial sometimes. Okay, so multiple pathology, multiple type of depositions. Okay, but because of this glomerular damage here, in this case, we'll be having a deposition towards the epithelial side. That means between the podocytes and my glomerular basement.
All right.
Now, see, because you're having a deposition of the immune complexes. Okay, so if immune complexes always deposit in like this kind of a patterns, this kind of a circular, they will form this like a masses. Okay, these kind of a masses they will form while depositing. So this will give you a granular or the lumpy bumpy appearance of the immunofluorescence. Okay, and yeah, that's what you find. Okay, these are all the immune complexes, as you can see. Okay, it is giving you a very granular appearance and very forming some masses, right? So these are all the immune complexes depositing towards the epithelial side along the basement membrane. Okay, subepithelial immune complexes. So that's thing what you will find on the electron microscopy. Any doubt in it? Now, after the immunofluorescence, you decided to run for the electron microscopy, and what you find on the electron microscopy is the subepithelial immune complex deposition, or you can say subepithelial immune complexes humps. Okay, let's say you have these podocytes here. Okay, you have these endothelial cells here. Okay, these are the basement membrane between the two. The basement membrane got damaged, and all these immunocomplexes they will deposit towards the podocyte sites. Okay, this kind of a thing will appear. Okay, that's what you will find on the electron microscopy. All the immune complexes will be depositing along the basement membrane. Okay, towards the epithelial side. Okay, so you call it a subepithelial immune complex deposition. Let me find a electron microscopy picture for you. Just give me a second. Look at this. Look at this picture also. This is again the capillary lumen, as you can see. These are all the endothelial cells. Okay, this is a basement membrane here. Okay, these are the podocyte foot. These are the podocyte foot processes, as you can see. Okay, and they are all effaced, right? You're having a deposition of all these immunocomplexes towards the epithelial side. Okay, that kind of a picture you will see. And this is all your Bowman's space where all the filtered, this fluid will be filtered here, right? In the Bowman's space ultimately. Okay, so the capillary lumen on this side. And where these kind of whitish structures, line-like thing, okay, it is always towards the epithelial side. As you can see here also, this is the epithelial side. Okay, this is the capillary part, and this is a subepithelial hump. Okay, similar thing you can find here also. These are all the subepithelial humps you can see. Okay, these things, these are all the subepithelial humps. Okay, so that thing you will see on the electron microscopy. So three things, remember, and this is kind of a lumpy bumpy appearance that we're talking about. All this granular type of appearance of the immunofluorescence. Okay, you will also have a linear appearance, which we'll discuss later. Okay, but please note that it is kind of very much granular, as you can appreciate if you guys, right? So this thing
Yes.
will be seen on the immunofluorescence of the APGN. Any doubt on the APGN? So first the patient symptoms, then you do the serological testing, then you do the this light microscopy, then the immunofluorescence, and then the electron microscopy. Learn them in this sequence. Now please ask any doubt.
No, thank you.
No, thank you.
Okay, second you have the rapidly progressive glomerulonephritis, or it is also known as a crescentic glomerulonephritis, because in all these conditions you will find the crescents, and these are the C-shaped structures that you will see on any of this case of rapidly progressive glomerulonephritis, the crescentic glomerulonephritis. Okay, these kind of a crescents we'll see. Now because of the inflammation, you will have a damage of the endothelium of the capillary, the basement membrane. Okay, all of these clotting factors, fibrinogen, okay, this fibroblast, they will leak towards the epithelial side, right? And there they will call us this fibrosis, and they will form this kind of a clotting, this kind of a structures, these crescents. So if the step one asks you what these crescents are composed of, they will be composed of a damaged endothelium, basement membrane, epithelium, fibroblast, inflammatory cells, okay, like the lymphocytes, WBCs, all type of WBCs, clotting factors will be present in this part. Okay, fibrinogen will be present in this part. Okay, so all these things will form the crescents, right? Now, first, you will do the light microscopy, and on the light microscopy, you will see the crescent shaped thing. Okay, and these crescents are composed of the fibrin, the plasma proteins, for example, all these immunocomplexes things, the IgG antibodies, IgM antibodies, C3b. Okay, the parietal cells will found there, right? Monocytes will be seen there, macrophages will be found there. Okay, other cells like the this fibroblast will also found there, right? So this is what you found on the light microscopy of a RPGN patient. Is that okay?
Yes, thank you.
And this light microscopy is common for all of the disorders that we will study now. Okay, in any of this disease, you will find the same light microscopy. This RPGN consists of three different types. One is the anti-glomerular basement membrane RPGN. Second is the immune complex RPGN. And third is the posse-immune. In case of my anti-GBM RPGN, as the name suggests, you're going to have a formation of anti-glomerular basement membrane antibody. So it is a kind of type 2 hypersensitivity reaction. You have no immune complex formation here, just the antibodies start depositing towards the honor basement membrane. Okay, and you will find a linear appearance of the immunofluorescence. In case of your APGN, you were having a granular appearance, right?
Yes,
In case of my this anti-GBM RPGN, you will be having a linear immunofluorescence, and that is the important thing. No glomerular thing, okay, no granular thing, no lumpy appearance. It's just a linear type of fluorescence you will see on the immunofluorescence. Okay, along with the antibodies against the glomerular basement membrane, you also have antibodies against the alveolar basement membrane, and as a result, you will have a hematuria with the hematmesis, cough with vomiting, cough with bleeding, as well as hematuria will be seen in the symptom of the patient. Okay,
yes,
and this disease is known as the Guth-Pasha syndrome. Antibodies against both the alveolar basement membrane as well as the glomerular basement membrane. So hematuria along with the hematmesis you will see on hemoptysis you will see on the patient symptom. Okay, edema will be there also again, oliguria will be there, hypertension will be there, dark urine will be there. Okay, hemoptysis is the addition thing that you will see on the Guth-Pasha syndrome. It is a type 2 hypersensitivity reaction. Treatment again is to eliminate all these antibodies from the body. So plasmapheresis will be given. Okay. Second type is basically a progression of the APGN into the RPGN, that is the immune complex deposition, RPGN. Okay. Again, on the immunofluorescence, you will find the granular type of immunofluorescence. Okay, because it is nothing but just a progression of the APGN in the adults specifically, not in the babies. Okay, not in the infants. It is always seen in the adults. Okay, adults with APGN, they will progress to the RPGN. Okay.
Yes.
The third type is the posse-immune. In this case, you won't have any deposition of the immune complexes or the antibodies. Okay. You have three types, and all of them we have discussed already. Okay. The glomerulopathy with polyangiitis or the vaginous disease, eosinophilic this glomerulopathy with polyangiitis, also known as Stokes disease, and the microscopic polyangiitis. And does anyone remember what antibodies we'll find here? And the microscopic polyangiitis, it will be MPO antibody, right? And the P ANCA. In the vaginous, it will be anti-PR3 or C ANCA, right?
Yes.
So these antibodies will be found in the serum. When you do the biopsy of the patient, you will only find the light microscopy positive of crescents. Okay, you won't have any kind of immunofluorescence. Okay, nothing, just a light microscopy. If you find a linear appearance in the immunofluorescence, it means it is a good Pasteur syndrome. If along with the symptoms of the RPGN, that means a crescent in the light microscopy, along with the granular immunofluorescence, that means it is a immune complex RPGN, which is a progression of APGN. Is that okay?
Yes.
So that's about the RPGN. Think about, whenever you encounter a patient, it will always be a edema patient, oliguria patient, hypertensive patient having a low GFR. You do the biopsy on the light microscopy, you will find a crescent. Now you have three things in the mind. It could be a linear, it could be a negative, it could be a granular immunofluorescence. You run the test for the immunofluorescence. What you will find is a linear, that means it is a good Pasteur. If you find a negative immunofluorescence, that means it is a vaginal Stokes or the microscopic polyangiitis. If you find a lumpy bumpy appearance, again along with this crescent, that means it is a the granular immunofluorescence or the this immune complex RPGN. Okay. Any doubt on this RPGN?
No, thank you.
Then you have the diffuse proliferative glomerulonephritis, and it is specifically seen with the SLE. I told you that in SLE, it can affect multiple organ systems like the kidney, like your GIT, like your heart, okay, like your lungs, brain, okay. Almost every system in your body could be affected with this SLE, okay. Now, in the SLE, you're having a deposition of the immune complexes. Is that right?
Yes.
And that's why you're having all this throughout the, and you're having all this inflammation in your body, right? Because of this deposition of immune complexes in various organ systems, right?
Yes.
The immune complexes are found against all the antibodies, against all these antigens to which these antibodies are forming. And does anyone remember all the names of antibodies you have seen in the SLE?
Anti-cardiolipin.
Yeah, anti-cardiolipin, but it is not a specific thing. Very important ones, anti-DNA antibody, for example. Anti-DNA antibody, anti-Smith antibodies, right?
Yes.
So when these antibodies found their antigen, they form the immune complexes. Okay, the anti-DNA and DNA immune complexes, anti-Smith immune complexes, they will form and they will deposit in the kidney, in the glomeruli, causing the diffuse proliferative glomerulonephritis. What you will see on the light microscopy is the wire looping of the capillaries. If you guys can appreciate this thing, right, this kind of a thickening, of the endothelium side will be seen. Okay, it will be a wire looping of the capillaries you will found. Okay, similarly, as you can see here also, the wire looping of the capillaries will be seen on the light microscopy of the patient with the DPGN. Okay, on the immunofluorescence, because it is an immune complex deposition, not the antibody deposition. In case of this good Pasteur syndrome, you are having an antibody deposition, but in case of other things, you will be having a immune complex deposition. So because of this immune complex deposition, the immunofluorescence always the granular type, the lumpy bumpy appearance again. On the electron microscopy, it could be a subendothelial immune complex deposition mostly. Sometimes it could be subepithelial or intramembranous also. It is often IgG based with a C3 complement deposition. It contains the DNA, anti-DNA immune complexes, Smith antigen, anti-Smith antibody complexes. Okay, this thing will be seen. So a patient having a pancytopenia, this malar rash, infection, joint pain, especially smaller joints. Okay. And having this flank pain and oliguria, think about that, DPGN and SLE. Okay. Is that okay?
Yes, yes.
Yes.
Okay, good. So, yeah, so it would be subendothelial, and because mostly it is subendothelial, it will cause the proliferation of the endothelium. So it will appear that the endothelium is very much thickened, right? So this kind of a wire looping you will see. So that would be all about it. Now comes the IgA nephropathy. Okay, and if you guys go back to the CVS, in the vasculitis, we have discussed one disorder, that is the IgA vasculitis, right?
Hershey.
No?
Henrich, yes.
Henoch-Schillen purpura,
Yes.
we're talking about, right?
Yes.
So IgA vasculitis we have discussed in the CVS part, and I told you you're having a formation of IgA antibodies after some kind of a GI or a respiratory tract infection, right? Any kind of a mucosal tract infection, right?
Yes.
You can have a formation of IgA antibodies, and now these IgA antibodies are forming complexes, and they will deposit on the tissues. Like in case of kidney, you will deposit, okay, on the kidney and causing the IgA nephropathy. Similar thing, if they deposit in the blood vessels, you will be having a IgA vasculitis, right?
Yes.
So the patient must be having a recent infection of GI tract or the respiratory tract. The infection could be present, and at the same time, patient develop all these symptoms with the ongoing infection, with this ongoing infection also, right? So a patient having a diarrhea or pneumonia or just a cough with running nose, he's having this hematuria. Think about the IgA nephropathy. Versus in case of APGN, the infection is over a month ago and now the patient is having symptoms. In case of my IgA nephropathy, the infection is still present, or the infection got over just 3 or 4 days before only. And now within 3 or 4 days, the patient develops this hematuria thing. Okay, that's how you differentiate between the IgA nephropathy and the APGN based on the symptoms. Okay.
Okay.
The time of presentation is very important.
Okay.
Now, okay, so now you're having the IgA antibodies, they will form the complexes and they deposit in the mesangium. Very important. You won't have any subepithelial deposits, you won't have any subendothelial deposit, but it is the mesangial deposits you will see. Okay, and what does this mesangium means?
The parenchymal cells?
Yeah, the parenchymal, actually the parenchyma is nothing but all these cells which constitute the kidney, right? So all these tubular cells, they're all the same cells, these cells, right? So it is not the parenchymal cells. The supporting cells, remember? You have this just let me draw this. You have this glomerulus here. Okay, you have this blood vessels here in the glomeruli, right? These are all the blood vessels in the glomeruli. In between spaces, you have some supporting cells, remember? That supports the glomerulus, right?
Yes.
And these cells are known as mesangial cells, remember?
Yes.
So you're having a deposition of the immune complexes in the mesangium of the glomerulus in case of my IgA nephropathy. That is the important thing. Okay, in the immunofluorescence, if you try to stain them with a regular staining, okay, with a regular of this stain like for the IgG or IgM or the C3, you won't find any kind of a this fluorescence. But when you stain the patient with the IgA staining, okay, you will find the deposits of the IgA in the mesangium. So that is an important thing. Regular staining won't work. You have to stain that tissue with the IgA immunofluorescence, okay? Because all the immune complexes are the IgA based. Is that okay?
Okay.
Now on the electron microscopy, you will find the mesangial immune complex deposition. That is again an important thing. Now please note how the patient will present you Once the patient got an episode of IgA nephropathy, okay, this episode got over. Then after again, 2 to 6 months later, patient again got an episode of IgA nephropathy. After 1 to 2 weeks, this episode got over. Then again, after 2 to 6 months, patient got a episode of IgA nephropathy. So patient will have a episodic hematuria. After every 2 to 6 months, patient will have a episodes of hematuria. You will immediately think about the IgA nephropathy versus in case of my APGN. Once the patient has an infection, okay, then after 2 to 4 weeks later, he developed the APGN. Okay, and it is a one-time effect only. Okay, it is only a one-time thing, but this IgA nephropathy, it happens multiple times. And with each episode, the severity of the disease will increase. And ultimately, the patient will have a renal failure because of this IgA nephropathy. Okay.
Yes.
So either it could be a patient having an ongoing infection, running nose, cough, maybe diarrhea, maybe, and now he's having a hematuria. It could be a patient who had these kind of episodes. Now, after 3-4 days later, he developed a hematuria. It could be a patient having an episodic hematuria. Every 2 to 6 months later, he developed the episodes of hematuria and hypertension and edema. Think about the IgA nephropathy. These three type of presentations will be present. Okay.
Yes.
Yeah, okay.
Okay. Now you have fourth type is the Alport syndrome, in which you're having a defective type of collagen, which is a type 4 collagen. Type 4 collagen forms the basement membrane, I told you already, right? In this case, you'll be having a thinning and splitting of the basement membrane. That's the important thing. Okay, and that gives a, very basket weave-like appearance of the basement membrane. Because of this thinning and splitting, it will give the basket weave-like appearance of the basement membrane. It's an X-linked dominant disease, so of course it will run in the families. So our family history is often very important. Patient will also have the eye problems. Okay, they will have an anterior lenticonus, which is a cone-shaped lens. The anterior part of the lens become very cone-shaped, so patient cannot see. Okay, the first thing is a blurring of the vision history or a blindness history. Second, of course, they will have a hematuria. And third is the sensory neural deafness. Okay, so they cannot see, they cannot pee, and they cannot hear a B. That kind of a presentation will be seen with the Alport syndrome. When you do the electron microscopy, you will find the thinning and splitting of the basement membrane, and that is the basket weave-like appearance. Is that okay?
How is that basket wave look like on the
Okay, let me open the electron microscopy for you. there is no high resolution image found. So
Okay.
this is a thing. But that kind of a, it's not very much clear, I know,
Yeah.
but that's what I found only. No,
Okay.
they don't have any SD image for this thing.
Okay.
So that kind of wave-like things you will see, you know, just like this crosses will found. If I found a good image, I will share with you, okay?
Okay. Thank you.
But there is no such image. So that's the Alport syndrome. They won't ask you electron microscopy, by the way. Just need to remember that they will have a splitting and thickening. You know, at some point the basement membrane will be splitting. At some point it will be thickened, right? So irregular thickening and thinning of the basement membrane will be seen, and that gives a basket weave-like appearance. So a patient who cannot see, who cannot pee, who cannot hear a bee, think about the Alport syndrome. Family history is always very important in them. Then you have the membranoproliferative glomerulonephritis, and it could be because of two things. Okay, the type 1 is because of the immune complex deposition. Okay, because of certain infection, some infection. Okay, the type 2 is basically the activation of the complements. Okay, in type 2, you're having an activation of the complements because of an autoimmune disease. In type 1, because of some infection, you're having a deposition of the immune complexes. The type 1 could be due to a hepatitis B, or mainly it is because of hepatitis C. It could also be idiopathic. Okay, you'll be having a C1q deposition in case of MPGN type 1. Okay, and it will be the subendothelial deposits with a granular, because it is always, and because it is the immune complex deposition, it will be a granular immunofluorescence like that. Okay, so subendothelial immune complex deposition will be C. The second one is a type 2. In this type 2, you're having a formation of IgG autoantibody that stabilize your C3 convertase. And whenever the C3 convertase got activated, it will convert the C3 into C3A and C3B, remember?
Yes.
The C3B will form the immune complexes, and as a result, you will be having a low level of C3 levels, low level of C3 complements, right? It will be a intramembranous deposits. Okay, and because of this intramembranous deposits, you will be having a splitting of the glomerular basement membrane, and that gives it a tram-tack appearance. In both the cases, you will have this deposit, so they will split the basement membrane and give them a tram-tack appearance. As you can see, this is the splitting of the basement membrane. You will see, right? This is one part, and this is the second part, and this is the splitting. So this gives a splitting that thing. Is that okay?
Yes. Thank you.
So know the cause of both of these. The first one is because of any infection like hepatitis C, for example. Mostly C1q deposits will be found on the subendothelial side. Okay, in case of my type 2, it is because of an autoimmune condition in which IgG antibodies stabilize the C3 convertase. So you will having a low level of C3 complements. All these complexes will start depositing in the intramembranous site. You will be having a GBM splitting and giving it a tram-tack appearance that you will see on the PAS staining or the H&E staining. Okay,
Yes.
so that's about the MPGN. Any doubt, please ask.
No, thank you.
Now you have the nephrotic syndrome, in which you're having a damage in the podocytes. And because of a damage in the podocytes, loss of negative charge happen, and that leads to a leakage of all these proteins from the kidney. The first one is the minimal change disease. Okay, in the minimal change disease, it can happen because of any inciting factor. It could be immunization, it could be a recent infection, it could be any immune stimulus. Anything which can generate the cytokines can cause the minimal change disease. When the cytokines generated, they will cause a damage in the podocytes that will cause the effacement of the food processes of the podocytes, and that causes the proteinuria. Because there is no inflammatory cell involved, on the light microscopy, the glomerular is always normal. You won't have any kind of hypercellularity, nothing will be seen. Light microscopy is always normal because there is no deposition of the immune complexes. The immunofluorescence will be negative. But on the electron microscopy, because of the cytokines, they're damaging the podocytes. On the electron microscopy, you will see the podocyte food processes effacement. Okay, and that causes the albuminuria. Is that okay?
Yes.
Yes,
So
yes.
a pediatric child having a history of generalized edema and a massive proteinuria. See, in case of my nephrotic syndrome, I was having a localized edema, mostly around the eyes and the ankles, right? In case of my minimal change disease or any case of nephrotic syndrome, it will be a generalized edema of the patient, right? So a pediatric child with a history of generalized edema, okay, and a massive proteinuria, the albumin will be the lost, okay? It can happen because of infection, immunization, and immune stimulus. In adults, this minimal change disease can occur because of Hodgkin's lymphoma. Okay, in adults, Hodgkin's lymphoma can cause the minimal change disease. While in children, it could be because of infection, immunization, or any kind of immune stimulus. Please note, no antibodies involved, no inflammatory cells involved, no immune complexes, nothing. Just the cytokines like the TNF alpha, interferon gamma, these interleukins, they are all causing the damage to the podocytes. So that's about the nephrotic syndrome. Now, because of this edema thing, okay, because you're losing all the albumin, okay, you're having a, this increase in the filtration of all this fluid from the capillaries, right?
Yes.
And when the fluid got filtered from the capillaries, it will start depositing in the interstitial space, and as a result, you will be having an increased lymphatic drainage, right? No?
What is that again, please?
See, because of this filtration of the fluid from the capillaries in the interstitial space of your body, you will be having an increase in the lymphatic drainage, because ultimately lymph is nothing but the interstitial fluid, right?
Right.
I told you in the CVS, also that this is your blood vessel. This is
Yes,
the
yes.
interstitial space. This is a cell. Whenever you have a filtration of the blood, right, it will always be carried by the lymphatic vessels.
Yes.
So because of this increased filtration, you will be having an edema, and that causes an increase in the lymphatic drainage of the fluid also.
Yes, got it. Yes, thank you.
And you also want to have an increase in the RAS also. Again, that is again an important thing, because yeah, so that will be seen in the minimal change disease. And does anyone know why this RAS is activating?
Because you're losing so much fluid.
Fluid, maybe.
Yeah, because you're losing so much fluid. Yes. So that causes the activation of RAS also, because ultimately because of this filtration, the intravascular volume will decrease, right? The intravascular volume will suffer
Yes.
because of this filtration. So ultimately, even though you're having a edematous state, the blood in your vessels is decreasing, and that activates the RAS. Okay.
Yes.
So a pediatric child with a history of generalized edema along with proteinuria with a negative light microscopy, negative immunofluorescence, and a positive effacement of the this full processes of these podocytes. Think about the minimal change disease. Second, you have is the focal segmental glomerulosclerosis, and as the name suggests, it will always involve some focal areas in your kidney. Okay, so just let me draw this. If this is my whole kidney, okay, for example, and this kidney has multiple glomeruli, right?
Yes.
This, in case of my focal segmental glomerulonephrosis, okay, you will be having a focal involvement and a segmental involvement of the glomeruli. Only some of these glomeruli will got affected. For example, this one, okay, and some part of this glomeruli will get affected only. Okay, so only some part of this affected glomeruli will be affected. So first it is focal, and second it is segmental. So only some of the glomeruli will be affected, and those who are affected, only some part of this glomeruli will be affected. Okay, this is the FSCS. It's happened because of, you must know that it happens after the HIV infection. It can happen in case of sickle cell anemia. It can happen because of the heroin abuse. Okay. Now, when you do the light microscopy, like I told you, because only some of the glomeruli are affected. Okay. So what you will see, this kind of a thing. If you zoom out on this picture, okay, if it's a real picture, okay, then you will see that some of the glomeruli are only affected. And those who are affected, only some part, as you can see, only some part of this glomeruli is sclerosed, thickened, for example, right? Sclerosis is a thickening.
Yes.
So a segmental thickening will open in the glomerulus. This is the FSGS.
Yes.
In the immunofluorescence, please note you have no immune complex deposition, so it is mostly negative. Sometimes it could be positive, but in the exam you will always find a negative case. So please note the immunofluorescence is always negative. Once you do the this electron microscopy, again, just like any other nephrotic syndrome, you will find the effacement of the food processes of the podocytes. Third you have is the membranous nephropathy, and this is the most common type. Okay, if you want to guess something, if you encounter a patient having a nephrotic syndrome and you do not know what to give the answer, give this membranous nephropathy. Okay, because it is a most common type. And in this case, this is the only nephrotic syndrome in which you have a deposition of the immune complexes. That is the most important thing. I told you in case of FSGS, in case of minimal change disease, you do not have any antibody involvement, you do not have any immune complex involvement, right?
Yes.
Similarly, in case of my diabetic nephropathy, you do not have any antibody or immune complex involvement. This is the only disease, the membranous nephropathy, in which you have an antibody, in which you have the immune complex involvement. Okay, this disease will see, it could be the primary. Okay, and whenever it is primary, it will be because of antibodies to the phospholipase A2 receptor. You call it an anti-phospholipase A2 receptor antibody, and these are IgG4 type. So remember the IgG4 antibodies and anti-phospholipase A2 receptor antibody. Okay, and this will be the primary cause. Secondary can be happen because of the NSAIDs, because of the penicillamine use. Hepatitis B can cause this, and SLE can cause it. So in the SLE, you can either have a nephritic syndrome or you can have a nephrotic syndrome. Mostly it is nephritic syndrome. Sometimes it could be the nephrotic syndrome also. Okay, it is a primary. If this is a primary disease, then it will poorly respond to the steroids, and ultimately it will lead to the chronic kidney disease. Okay, on the light microscopy, you will see that diffuse capillary as well as the glomerular basement membrane this thickening. Okay, because of a deposition of these immune complexes towards the endothelial side. So a diffuse thickening of the capillary will be C, as you can see in this case also. A diffuse thickening of all these capillaries is seen, right?
Yes.
Yeah. Look at that part. This is a capillary, and you're having a thickening of this thing, right? Now, because of a deposition of the immune complexes, okay, you will have a spike and dome appearance of the subepithelial deposits. Okay, a spike and dome appearance is very important. See, you have this basement membrane and you have the podocytes. Okay, when the immune complex got deposits, like this is a part. Okay, this is one immune complex. Okay, and now you have is a second immune complex, and then again a third immune complex for say. So as you can see, you will have this kind of a dome, okay, and then a spike, then a dome, and then again a spike, right? Then a spike and then a dome. So this gives a dome and a spike appearance to the deposits. Is that okay?
Yes.
So that kind of a thing you will see on the electron microscopy of the patient, the spike and dome appearance of the subepithelial deposits. Spikes where the these immune complexes are not present, and dome where the immune complexes are present. Okay, and of course, when you do the immunofluorescence, you will find the granular deposits, the lumpy bumpy appearance again. So the linear appearance only in one disease, which is the Good-Pasture syndrome. And the lumpy bumpy can be found in other diseases, right?
Yes.
So that's about the membranous nephropathy. Any doubt, please ask.
If you go up, not on the membranous one, but the one that we had before. Can you scroll up? Yeah. Is it that the heroin is causing direct damage, or is it because heroin abusers are more likely to have HIV in focal segmental?
Yeah, heroin abusers can have a HIV mostly. That is the most important thing.
Okay, it's not the direct heroin abuse.
No.
And then how is obesity going to cause this? Because it's an inflammatory state?
Yeah, exactly. You can have an inflammation in the obesity. Remember this, what you call the anemia of this chronic disease?
Yes.
Remember? I told you that, whenever you have a obesity or the chronic heart failure, it causes a chronic inflammation in your body, right?
Yes.
So it will put an extra load on your kidney also, and that causes a sclerosis or a thickening of this kidney, right?
Okay.
Interferon
Okay.
treatment again can cause a release of cytokines that can cause the damage. Malformations can again happen, right?
Yeah. Okay, that makes sense. Thank you.
Thank you.
So that's about the membranous nephropathy and the FSCS. Please note, a patient with a heavy proteinuria and a deposition of the immune complexes, please go for the membranous nephropathy, not the nephritic syndrome. Because, and if they ask you, what they will just give you a case of this heavy proteinuria, and they will give you some kind of electron microscopy showing some kind of immune complexes, and they want you to know that this must be a case of membranous nephropathy, because only in case of membranous nephropathy you can have immune complexes. No other case of this nephrotic syndrome can have this immune complexes. Okay.
Yes.
Third thing you have is the amyloidosis. Okay, you always have a deposition of the amyloid around the blood vessels, right?
Yes.
So you will have a deposition of the amyloid, and it will appear as a diffuse pink thing on the glomerulus. Okay, diffusely pink appearing glomeruli. Think about the amyloidosis. Okay, you do the light microscopy. In the light microscopy, you will do either the H&E staining. Okay, on the H&E staining, you can you will see this kind of a thing also. Okay, and you might confuse it with the diabetic nephropathy, but please note, in case of diabetic nephropathy, you can have some cells in between. But in case of amyloidosis, it will be a diffuse pink thing, no cell in between. Okay, as you can see, you have some cells here, some cells here, some cells here, some cells here, right?
Yes.
And these deposits are very much small. In case of my amyloidosis, it will be diffuse pink without any cell. Okay. You can do the this congruent staining. You will find the red deposits. Apple green bifringence, it will give you the green appearance under the polarized light. And that's how you know that the patient is having a amyloidosis. And please note, just like the IgA nephropathy, amyloids always deposits in the mesangium of the glomerulus. Okay. Any doubt?
No, thank you.
Let me show you the light microscopy of the amyloidosis. Give me a second. Appreciate this.
Yes.
That diffuse pink without any cell involvement, right? Similarly, on this also, You can see a diffuse pink deposition without any cellular involvement. This is the amyloidosis. Versus if I open up a case of your diabetic nephropathy, sure, you will see the deposits, but they also have the cellular involvement, right? As you can see, you have this kind of a cellular involvement always. So that's how you differentiate between an amyloid deposition and this the KW nodules. Okay.
Okay.
Now comes the diabetic glomerulonephropathy. Okay, it always happens after 5 years of the diabetes. Please note the time. It not just the patient is having a diabetes and they suddenly develop uh, uh, this nephropathy. Okay, they must have a time period for the development, right? So this nephropathy always happens after 5 years of the diabetes. It takes time to develop this disease, right? So you will only suspect the nephropathy case in a patient having a diabetes for more than 5 years. Now, because of the hyperglycemia, okay, you will be having a non-enzymatic glycosylation deposits on the efferent arterioles, remember?
Yes.
Because of this deposition, you will be having a high pressure on the glomerulus, and that will cause a thickening of the glomerular basement membrane, right?
Yes.
You will have a thickening of the glomerular basement membrane. Because of this high pressure, you also need to expand the mesangial cells to support more. You need more support now because of this high pressure, right?
Yes.
Now, all these non-enzymatic glycosylation products, they will start filtering because of this damage in the glomerular basement membrane and all these things. Okay, so all these, just give me a second. Yeah, all these products will start filtering and start depositing in the glomeruli, forming the KW nodules or KW lesions. Okay, and you will have these kind of a KW nodules in the diabetic glomerulonephropathy. Is that okay? Because of this hyperfiltration, because of this high pressure, you will be having a more filtration fraction, more filtration of these products will occur. And because of this more filtration, they will start depositing in the glomeruli, giving the KW nodules. Okay, this kind of a nodular appearance you will find. Is that okay?
Yes.
And because they are the deposits of the glycoprotein, they're always pass positive, right?
Yeah.
Yes.
You guys are having some doubt on this thing? Should I repeat some line again?
No, no, good, thank you.
Filtration is
Okay,
due
so
to
please note. Yeah. Yeah.
the hyperfiltration is due to the hyperosmolarity, which means you have more water inside your blood.
See, many things are actually happening in diabetes. One thing is because of this increase in the this filtration fraction because of the constriction of this efferent arteriole. Second thing, you're having a high glucose load in the blood, so it causes more filtration of the glucose, right?
Oh,
Yes.
okay. Because you are depositing in the efferent arterioles and also because water will follow glucose.
Yeah, exactly. Both in the efferent arterioles as well as in the glomerular itself, I'm having a deposits of these things. Okay.
Okay, perfect. Thank you.
In both the locations. So ultimately, you'll be having a damage in the glomerular because of this high pressure injury will happen. More filtration will happen. That forms the KW nodules, damaging the kidney function because the remaining parenchyma of the kidney need to compensate, right? So you will have a loss of GFR, and this oligourethane ultimately the kidney failure will develop. Please note, no immune complex deposition, just the pass positive material will deposit in the glomerulus. Okay. And that's why you need to give the patient ACE and ARB therapy so that you can relieve the pressure on the glomerulus by dilating the efferent arteriole, right?
Yes.
So that's about the diabetic glomerulonephropathy. Only happens after 5 years of the diabetes, not before 5 years. Up to 5 years, it's all compensated. no damage. Okay.
Yes.
Okay, so we will take a short break, and after a short break, we will discuss further about this diabetic nephropathy in detail, about all these timelines and all this kidney failure that will happen after the diabetes. Okay.
Okay, thank you.
Sure. So this is a natural history of a diabetes patient. See, what happens when the patient develops diabetes? Now, because of an increase in the glucose load of the patient, I told you whenever you have a high concentration of any substance, the filtered load of that substance will increase, right? Remember, filtered load?
Yes.
So because of this increase in the filtered load, okay, I told you that you have receptors for the reabsorption of all this glucose, the SGLT2. As the filtered load increase, the saturation limit of all these receptors will reach,
Yes.
right? Remember? Now,
Yes.
because because of this increase in the filtered load, the reabsorption of the glucose is also increased by these receptors, and as a result, the sodium oil will also be absorbed by these receptors, right? Along with the glucose.
Yes.
And as a result, the delivery of the sodium to the this macular cells is decreased now. If I'm having a too much of glucose in my PCT, okay, the reabsorption of the glucose will increase via the SGLT2 receptors. Along with the glucose, sodium also get reabsorbed, and as a result, the delivery of the sodium to the DCT or the macular cells will decrease.
Yes.
Yeah.
Now, when the
Yes.
delivery of the sodium to the macular cells is decreased, you will have an activation of RAS.
Yes.
And the function of RAS is to constrict the efferent arteriole to cause an increase in the GFR, right? Ultimately.
Yes.
So as a result, in a very initial time, you will be having an increase in the GFR when you get the diabetes. Okay.
Yes.
Because of this increase in the GFR, the pressure on the glomerulus will increase. And as a result, you will be having a glomerular hypertrophy.
Yes.
Okay. Now comes the second part. After 5 years, because of this continuous increase in the glucose load, what's gonna happen? You will be having this deposition of all these glucose products in the efferent arterioles, and that causes increased pressure, further increase in the pressure of the pressure on the on this, on my this
Different.
basement members and the mesangial cells, right? This pressure will be increased, and as a result, the glomerular this basement membrane must be thickened in order to counteract this pressure, right?
Yes.
Similarly, the mesangial cells also need to expand in order to support my glomerulus due to this high pressure. Now, as a result, I will be having a mesangial expansion and the glomerular basement this thickening. That's exactly what you will see on the nephrotic syndrome. After 5 years, I told you, right?
Yes.
In this 5 years, after 5 years, the GFR will start falling. Initially, it will rise before 5 years. After 5 years, the GFR will fall and the albumin start appearing in the urine because of a nephrotic syndrome, right? You will get the arterial hyalinosis because of this deposition of all these non-enzymatic glycating products in the efferent arteriole. You will be having the arterial sclerosis. Remember the previous lecture we have discussed hyaline atherosclerosis
Yes.
and the hyperplastic one, right? So hyaline atherosclerosis will be seen. You will be having a moderately increased albuminuria because of a damaging in the food processes of the podocytes, and you will be having a hypertension. Now, after 15 years, the GFR will start falling rapidly and the albumin start rising rapidly. And what you will get is the overt diabetes mellitus. In that case, you will see the KW nodules. Okay, overt proteinuria will be seen. GFR will be falling. Okay, you will get, and because of this fall in GFR, you will be having a kidney failure ultimately. Right?
Yes.
So what could be the treatment? Of course, the ACE inhibitors, R inhibitors. To decrease the pressure, to decrease the proteinuria, you can also give the patient non-dihydropyridine calcium channel blockers. Okay, but they're not as much protective as these ACE and ARBs. So these are the primary, or you can say the first line therapy to prevent the kidney damage in the diabetes. In order to manage the, in order to monitor the kidney damage, you have to measure the albumin-urea of the patient. Because as you know, as the kidney damage progress, the albumin level in the urine will keep on increasing. Right?
Yes.
You can check the glucose level also, but the glucose level only reflects the, this glucose in your body. Okay, the glycemic control of your, right? The glucose levels only represent the glycemic control, right?
Yes.
So in order to get how much kidney is being damaged now at this point, you need to measure the albumin level. So by measuring the albumin concentration in the urine, okay, you can easily measure the degree of renal damage in the diabetes mellitus.
Yes.
So that's about a natural history of a patient with the diabetes. Initially, in few before 5 years, the patient will have an increase in the GFR because of increase in the glucose reabsorption by the SGLT2 and decrease sodium supply to the kidney, to these macular cells. Eventually, you'll be having a fall in the GFR. Okay, when the glomeruli start getting damaged, you'll be having a fall in the GFR and the albumin-urea. Expansion of the mesangium will occur. Glomerular basement thickening will occur. Hyaline arteriosclerosis will happen. Albumin-urea will happen. After 15 years, over diabetes mellitus, a very rapidly falling GFR and rapidly rising albumin-urea will be seen. GFR falling, chronic kidney disease, all this uremia and all other things of the renal failure will develop. GFR will be falling. Proteinuria and KW nodules will also found. Any doubt, please ask.
I just want to one thing. So, according to this explanation, the early sign of diabetic nephropathy is the albuminuria.
Yeah,
And
exactly.
GFR
No.
and the rise in creatinine, they will come later.
Yeah, exactly. No, actually it happens, a very slight rise in the creatinine you will see. Because, GFR is actually falling, but very slightly.
Okay,
Right?
not significantly, right? Okay.
Not significantly. The significant fall always happen after 15 years, as you can see.
All right.
Right?
Okay.
That is the important thing.
All right. Thank you.
Any more doubt on this thing, the nephropathy?
No, thank you.
No, thank you.
Okay. Now let's again go back. Look at this electron microscopy. Now, can anyone tell me which part is the endothelium and which part is the epithelium?
On which one, A or? Okay.
Look at this electron microscopy. Okay. In this figure, in this picture, which part is the epithelial side and which part is the endothelium side? You need to be able to identify that, right? So tell me which part is endothelium and which part is epithelium.
The blackish one.
See, you have one part which is the reddish. Okay, this red area. Okay, and you have the opposite part here, this one. Okay, so which part, this red area part or this part? Which one is the epithelial side? Anyone?
Outside one is the.
This one or this one? This
the other
one?
one.
This one? Yeah.
Yeah.
Okay, no, this is not the epithelium. This is the endothelium side. These are all the blood vessels. Okay, how can you identify the epithelial side? See this kind of a thing. I told you this line-like structures you will found, right? And these are the food processes. Okay, these are the food processes of the podocytes. And this whitish line-like thing that you will see on whatever side, okay,
Mhm.
that will be the epithelial surface.
Okay.
Okay, as you can see, the photocyte food processes are present here, but they're
Mhm.
effaced here. As you can see, there is no food processes found here, right?
Okay.
So this is the effacement of the food processes of the podocytes. Okay,
Okay.
so it will be very important for you to identify the epithelial side and the endothelial side. So this, as you can see, these are all the endothelium cells. Okay, this is a basement membrane, and this is the epithelium surface showing the podocyte food processes. Okay, you can even find the RBCs here. Unfortunately, no RBCs present right now. Okay, so yeah, this is the basement membrane. This is the epithelium, and this is the endothelium. Okay, these line-like structures you will found always on the epithelial side. Okay.
Okay.
Now, because of the nephrotic syndrome, you will be having a loss of oncotic pressure that causes a fluid leakage, and as a result, you will have an edema. Intravascular volume will depleted. You will get an increase in the RAS. Aldosterone levels will be rising. You will be having a reabsorption or a retention of the sodium and the water that will worsen the edema of the nephrotic syndrome. Okay. So that's everything on this page. Any doubt on the nephrotic or the nephrotic syndrome, please ask.
No, I'm okay.
No, thank you.
Okay, now you have different type of stones. Okay, so what is the symptom of having, how can you say that the patient is having a renal stone? They will always present you with a unilateral flank pain and tenderness, of course, that will radiate to the groin. So whenever you see this kind of a presentation of flank pain radiating to the groin, always think about the kidney stones. Okay, hematuria will also be seen. Of course, you will have a hematuria, flank pain that radiates to the groin. That will be the kidney stones. Now, see, you also have this flank pain and the hematuria in case of my renal infarction, right? The tenderness will be there, the pain will be there, hematuria will be there, right?
Yes.
So, how would you differentiate between the renal infarction and the renal stones?
Renal stone, hematuria.
In both the conditions, in the infarction, you will have the hematuria and this flank pain. Similarly, in kidney stones, you also have the hematuria and the flank pain. So how would you differentiate between the infarction and the stones? That you must know, because you will encounter some patients for that.
The cast, like if something related to injury to the renal parenchyma, so the cast will be there along with the hematuria. While in the ureter or something with the bladder, only the plain hematuria will be there.
If you go back and look in the cast section, okay, we have not shown any of this necrosis with the cast, right? Except for the ATN, of course. See, in case of my renal infarction, you're having a blockage in the renal artery, right? The main artery is get blocked. So whole kidney will die, right?
Yes.
Okay.
So you cannot expect a cast. So exclude this now. So see, again, you are having a flank pain and a hematuria. How will you again differentiate between the stones and the infarction?
Do you look at serum osmolarity?
Osmolarity, no. Think again. I told you, whenever you have a pathological injury, a necrosis, okay, what follows necrosis always? Generally, as a general, what will follow necrosis whenever you have a cell injury, a necrosis? What will happen after that?
Renal failure?
Of course, renal failure will. Scar tissue happen very late. Just immediately after the necrosis, what will happen?
Death.
After that, of course, generally what happens?
Neutrophils come try to clean up.
Neutrophils come. Yeah, neutrophils will come, and that will cause the inflammation.
Yeah.
And whenever you have the inflammation, what is the sign of inflammation? Systemic sign?
Edema.
Edema, of course. Okay, you will have a renal failure that can cause the edema also. But again, the systemic sign of inflammation, other than the edema.
Fever.
Fever, exactly. You will have a fever. Okay. And because the kidney is getting damaged, you're having a blockage in the blood vessel supplying the kidney. Okay, the perfusion of the kidney will drop, right?
Increased BUN creatinine.
And you will get a RAS increase, right? You will have an increase in the BUN levels, creatinine levels. The RAS will increase. That will cause a high blood pressure, okay, right?
Right.
So a flank pain, tenderness, fever, high blood pressure, edema, these are all the signs and symptoms of the renal infarction. Versus in case of your kidney stones, you will just have the tenderness that radiates to the groin and hematuria. No cast will be found, no fever will be there, no RAS increase will be there, no blood pressure, okay?
Okay.
Okay.
Should I repeat myself again?
No, thank you. No, I got it.
These are the important differentiating factors between the kidney stones and the renal infarction. And apart that, history is again very important. Most of the cases of the renal infarction, they must be having a arrhythmia, right? Because I told you, whenever the patient is having a arrhythmia, they must be having they will be having an increased risk of developing an embolus, right?
Yes.
Other than that, patient can also have a history of atherosclerosis. So look for the patient history. Look for the symptoms of the patient apart from the flank pain and hematuria. If he's having a slightly increased temperature along with the high blood pressure, because a high blood pressure means you're having a blockage in the kidney, right? Versus all these things they won't see in the kidney stones. Okay. Now let's discuss all these stones now. Yeah, first is the calcium stones. You have two types of calcium stones. One is the calcium oxalate stones, and second is the calcium phosphate stone. Calcium phosphate stones forms whenever you have a increased pH. Okay, and the calcium oxalate stones form whenever you have a decreased pH. Okay, so whenever you have an acidic urine, you will have a calcium oxalate stone. Whenever you have an alkaline urine, you will have a calcium phosphate stone. Okay.
Yes.
Because they are calcium stones, they are always radio opaque. When you do the X-ray of the patient, you can easily identify where the stone is present. It will be seen as a very enhanced mass-like structure in the ureter, and you will immediately know that the patient is having a blockage in the ureter at some point. CT, again, you will be having a radio opaque structure. Okay, it will be having an envelope or a dumbbell shape, as you can see. This kind of an envelope or a dumbbell shape of structures you will see on the microscopy, urine microscopy you will perform, you will see these kind of stones, envelope shaped stones. Okay. So calcium stones are of course the most common stones. They are almost 80% times when the patient has, it will be the calcium stones. And the calcium oxalate stones are more common than the calcium phosphate stones. Okay, these stones can be happened after the ethylene glycol use. I told you, whenever you drink the ethylene glycol, it will cause the renal damage. It can cause the acute tubular necrosis. It can cause the renal stones. So antifreeze drinking can cause it. Vitamin C abuse. Remember, why this vitamin C?
Vitamin C causes increased iron absorption, which makes everything more acidic. So I thought that you would get more
That is a
calcium.
very good correlation, but yeah, that is not the important thing. 100 marks for the correlation. Vitamin C can cause a high iron absorption that can cause acidemia. But the other important thing I told you in the biochemistry section, that this vitamin C, it become a metabolite. And does anyone remember the name of that metabolite?
Citrate.
Oxalate.
Oxalate.
Yeah. The metabolite of the vitamin C is the oxalate, and that's why it will cause the oxalate stones. Okay, go back to the biochemistry. You will see, in a very last, I think it is written in the side effects of the excessive vitamin use. Okay, because vitamin C become a metabolite, that is the oxalate, and that can cause the oxalate stones. Hypocitraturia, because in case it will be happen in the distal renal tubular acidosis. Okay, you will be having this urine pH very much decreased. Okay, and that can cause the calcium oxalate stone formation again. Sorry, yeah, you will have a this oxalate stone formation again because of this hypocitrate urea. Okay, because you need the citric acid to increase the pH, right? Having a doubt?
Sorry,
Yeah.
can you repeat what you said?
See, to having a hypocitrate urea, and that happens in the distal renal tubular acidosis. And I told you in every case of distal renal tubular acidosis, you will be having a
You would have the tubular alkalosis.
yeah,
and
exactly, metabolic acidosis, right?
Yes, metabolic acid.
Yeah, so that will cause the oxalate stones in the hypocitrate urea. Okay.
Okay.
And one important thing is also that the citric acid always solubilize this calcium, so prevent the calcium oxalate stone formation. Okay, so that's why because of this hypocitrate urea, okay, this cannot be combined with them, and as a result the calcium will combine with the oxalate that will cause this stone. Okay.
Okay.
Any doubt in that part?
Can you repeat it?
See, how can I describe you? Just give me a second. See, what happens is whenever you have a citrate, okay, this citrate will bind with the calcium and cannot let it bind with the oxalate.
Yes.
So if the
Yes.
citrate is present, then this citrate will bind with the calcium, and as a result, calcium oxalate stones won't form. In case if you have a hypocitrate urea, okay, the citrate cannot bind with the calcium. Now this calcium will bind to the oxalate, causing the calcium oxalate stone formation. Now is that okay?
Yeah, no, that
Clear.
part that I'm confused
Am I
about
okay?
is renal
Yeah.
tubular.
Yeah.
Is it? Okay. You don't have citrate, right? Citric is citrate.
Citrate.
Why is the lack of citrate giving you distal renal tubular acidosis? I think I'm mixing two concepts.
See, you're asking how this this hypocitrate urea causing the stones, right?
Okay. Is the hypocitrate urea related at all to the distal renal tubular
Yeah,
acidosis?
it happens in the distal renal tubular acidosis. It happens in it, right?
Okay, so the distal renal tubular acidosis is causing the hypocitrate
Yeah,
urea?
exactly. Yeah, exactly.
Okay.
Although you can also have some deficiency with other things also, but this is also a cause of it. Okay.
Okay. Okay.
This is also a cause. So in all the conditions, you will be having a hypocitrate urea, and that will form these stones. You need the citrate to form to combine with the calcium, so that the calcium cannot combine with the oxalate. In case of the deficiency, you will be having a calcium combining with the oxalate, forming the calcium oxalate stones. Again, the malabsorption, like the Crohn's disease, I told you, whenever you have a fat malabsorption, you will be having a lot of fat in the intestine, right? And now the calcium will combine with that fat, with the saponification, right?
Yes.
If the calcium combined with all these fats and being excreted from my body, now the oxalate can be absorbed in my GIT. Because naturally
Yes.
what happened is whenever you ingest the oxalate, the calcium will combine with the oxalate in the GIT, and this excretion of the oxalate happens. But now the calcium is not available, and as a result the oxalate will get absorbed in my body. It will reaches to the kidney, okay, and then in my kidney it will combine with the calcium to form the calcium oxalate. So a Crohn's disease can cause the calcium oxalate stone formation. Okay.
Yes.
And that's because of the over absorption of the oxalate. So these are all the causes of my calcium oxalate stone formation. Treatment again include giving the patient thiazides, because by giving thiazides, I will have an increased reabsorption of the calcium. So less calcium in the tubules, less stone. You can give the patient citrate so that it could be combined with the calcium. You will give the patient low sodium diet also. Okay, and you will also increase the calcium in the diet, because if you decrease the calcium in the diet, in that case you will have a less GI calcium, and again you will have a more absorption of the oxalate, right?
Yes.
So
Okay.
one of the treatment is to increase the calcium in the diet, but please make sure you need to give it a very defined amount. Okay, you cannot cause the hypercalcemia to the patient, because if you cause the hypercalcemia, again you will have a kidney stones. So a maintained amount will be given, right?
Yes.
So these are all the treatment of the calcium oxalate stone formation. Please note they all form in the acidic urine. In the basic urine, you can have a calcium phosphate stones. Okay, and they're again radio opaque. They have a wedge-shaped prism structure, although they have not shown it here. Okay, so they have a prism-like structure, and again the treatment includes the thiazides and the low sodium diet. Third one is the ammonium magnesium phosphate, also known as the struvite stone, and that happens after the recurrent infections of the kidney, after recurrent UTI. You know that you have the bugs like the Proteus mirabilis, Staphylococcus saprophyticus, and the Klebsiella. I told you already that these all agents, they all bugs are urease positive, right? Remember the
Yes.
urea plasma and all of these
Yes.
things, right? So the Proteus mirabilis, saprophyticus, and the Klebsiella, they all have the urease enzyme, right? So they all will convert, this. Just give me a second. Yeah. They all will hydrolyze the urea into the ammonia, right? The urease enzyme will hydrolyze the urea into the ammonia, making the urine alkaline. And that causes the formation of ammonium magnesium phosphate. You have the ammonia in the urine, okay, and you are also having a very high pH because of this recurrent UTI. And now this ammonia will combine with the magnesium and phosphate to form the ammonium magnesium phosphate stone. So clinical features, always the patient will have a history of recurrent urinary tract infection. And now even this time when the patient present with the in the department with the stone, they again have an infection episode. So the patient will be having this, urgency, frequency, okay, pain with the urination will be there, right? And the patient will have a flank pain that radiates to the groin along with the infection again, okay. And then you do the CT of the patient, and what you will see is this kind of a stone. Okay, this is all enhanced mass. It's the stone actually. Okay, this will block the renal this outflow tract completely, and that causes the atrophy of the kidney. The pressure atrophy of the kidney will happen. Okay, so one kidney is enlarged, which is a normal kidney, and one kidney is very shrunken, and that is the abnormal kidney. Okay, that you will see on the CT or the MRI of the patient. Okay, when you do the once you do the this urine analysis, what you will find, these kind of a coffin lid like appearance of the stones. These rectangular stones you will find, and this is the struvite stones. Okay, so coffin lid like appearance will be there. Stagon calculi, and you will see that on the CT of the patient. Okay, atrophy of the kidney is very important. Now the treatment, again you need to give the patient, of course, antibiotics first. You need to eradicate the underlying infection, because once the when the patient present you with these stones, they have this ongoing this infection, right? They have this ongoing UTI, so you need to eradicate this UTI by giving the patient antibiotics, and then you need to surgically remove this stone. Okay, so history of UTI, Stragon calculi, flank pain, fever, infection, and the atrophy of the parenchyma on the CD. That all things will be found in the this struvite stones. Any doubt? Please ask any doubt.
No, it's clear.
Okay. Then you have the uric acid stones, and those stones are formed whenever you have an acidic urine. And if you go back and think about all these parts of the nephrons, the glomeruli, the PCT, loop of Henle, DCT, collecting duct, you find that the acidic portion is the DCT and the collecting duct. The most acidic portion is the DCT and the collecting duct, and that's why these stones are mainly found in the DCT and the collecting duct, because you have all this acid secretion there and the absorption of bicarbonate from there, right?
Yes.
So the most acidic portion is the DCT and the collecting duct, and that's why most commonly these stones are formed in the DCT and the collecting duct. Okay, and the uric acid stones formed whenever you have a high uric acid level, and that happens with the gout and all the causes of the gout. Of course, that the tumor lysis syndrome, the tumor itself, the hyperuricemia, all the causes, like decrease excretion and increase in the formation. Okay, so all of them can cause the uric acid stones. And please note, with the acidic urine, you will form this stone, and that happens in the DCT and the collecting duct mainly. Okay, they will appear as these kind of rhomboid shaped. Okay, these kind of rhomboids will found on the urine microscopy of the patient. Okay, so treatment again include giving the patient alkalization and giving the patient allopurinol. And does anyone remember the function of this allopurinol?
Used for gout.
Then those
Xanthine oxidase inhibitor. Yes. Okay. So that's about the uric acid stones. Remember, the low pH, acidic pH will form the stone. Okay, high level of uric acid will be found, of course, all the causes of gout, tumors, okay, and tumor lysis syndrome, and all other things. DCT and the collecting duct are the major portions where you find these stones. Any doubt, please ask.
Oh, that's okay.
No.
And please note that these stones are also radiolucent, and that means even if you do the X-ray of the patient, you cannot find anything on that. Okay, like in case of my this ammonium magnesium stones, or the calcium phosphate stones, or the calcium oxide stone, you will find the stone obstruction on the X-ray, abdominal X-ray of the patient. But in case of the uric acid stone, you cannot find any stone on the X-ray of the patient. Okay, the only thing you can do is to do the urine analysis of the patient and check whether he's having these kind of stones or not, and check the uric acid level. Again, you will find a high uric acid level or any of these comorbidities. Okay, then you have a cystine stone, and if you guys go back to the biochemistry, we have discussed about a disorder in which you cannot reabsorb the amino acids. Remember, the cysteine, ornithine, lysine, and arginine.
Yes.
Okay, so and it is an autosomal recessive condition, right? The cystinuria. Okay, so in that case, you cannot reabsorb the cysteine, ornithine, lysine, and arginine, and as a result, all of these amino acids will appear in the urine. Cysteine, in presence of an acid in an acidic pH, it will form the cysteine stones, and these stones are appear as these hexagonal stones. Okay, that thing will be C. So please note the defect lies in the proximal convoluted tubule transporters. These transporters become defective and they cannot reabsorb the cysteine, ornithine, lysine, and arginine. Right. So the treatment again include is to make the urine very alkalized. Okay, important thing. And if you guys remember the sodium nitroprusside test, the sodium cyanide diphosphoride, this test, nitroprusside test, it is also used for a diagnosis of the cysteine urea. Okay. So treatment include giving the patient alkalization. Chelating agents like the penicillamine can also be given, and again a low sodium diet will be given for the treatment. Okay, these stones are very faintly radio opaque, so again they might or might not be appear on the X-ray of the patient. Okay, so the important thing you can do is the urine analysis of the patient. Checking the this urine microscopy, you will find these kind of hexagonal stones. Other important stone which is not given here are the needle-shaped stones. Okay, and that's seen with the acyclovir therapy. Okay, acyclovir is a drug you will use for the herpes simplex virus infection, and and if you go back and look for the side effects of this drug, you will find the kidney stones there, right?
Yes.
So whenever you see the needle-shaped stones on the urine analysis, think about the acyclovir therapy. The needle-shaped crystals in the joints found in the gout, in the uric acid, okay, but the needle-shaped crystals in the urine are found in the acyclovir therapy. Okay, and apart from this alkalization, giving the patient antibiotics or other thing, the most important thing you can do to eradicate these stones is to give the patient hydration. Okay, you need to excessively hydrate the patient. You need to ask the patient to drink 6 or 7 liters of water daily, okay, in order to decrease the risk of any of these stones. So if the step 1 asks you a universal treatment, it will be giving the patient hydration. While for a specific treatment, you can either alkalize the urine or acidify the urine respectively, okay?
Yes.
So an increase in the fluid intake can reduce the overall risk of any type of stone. Important point. So any doubt on the stones?
So is the cystine stone, is that essentially, is that a Fanconi type syndrome?
Yeah, cystine stones can be formed in the Fanconi syndrome also, because in the Fanconi syndrome, you're having a generalized defect. And in that case, everything that was being reabsorbed in the PCD is getting lost now. Okay, so this kind of thing can happen with the Fanconi syndrome also.
Okay, but it can't cause Fanconi. Okay, I understand. Okay.
Yeah. So any more doubt on any of the stones? Please ask.
Oh,
They're
sorry.
using a low sodium diet because of the RAS activate to prevent that one everywhere.
Please repeat it again.
We are using the low sodium diet. It's because of the RAS thing.
Yeah, RAS and other many things also.
Okay.
It is kind of very much complex again.
Yes. Good,
Not
good.
that much simple. And one more thing, I told you that whenever you have a dehydration or low water, then only you can have a stones, right? Because dehydration will prevent the stone formation. Okay, doesn't
Yes.
matter you're having an alkalination or acidification of the urine. If you give the patient excessive hydration, then they won't have the stones, right? So the stone formation only happens whenever the urine become concentrated, and in that case, you will see and you will look for the option. You will look in the patient history also that they always have a specific gravity of more than 1.015. You don't need to know that. Just whenever you read the vignette of the patient, you can feel it that they always give you a specific gravity of around 1.015. Okay, and that will give you a thing that the patient is having a concentrated urine, and that is forming the stone in his body. Okay, you can feel it while solving the questions also. Okay.
Okay.
So that's all about the stones. And please note, you cannot find the cast in the urine because it is a pathology below this kidney, right? So RBC cast won't be present. It is just a hematuria. You have lots of RBCs in the urine, but no RBC cast. Okay, again, important thing. So let's wind up here for now. Okay.
Okay.
We will discuss the hydronephrosis and the urinary incontinence, and we'll finish this chapter tomorrow. Okay.
Thank you.
Okay, thank you.
Thank you.